I think a trip to medical records in the old days, seeing that patients were being turned to collections for really outrageous amounts for reasonable procedures, that was bad. And I felt like an accessory to a crime.
We've got to change this system because people are hurting. That's not good for productivity. It's not good for job satisfaction. And it's not good for them too, because they're paying so much that they don't need to pay because of this system. And a lot of the money that they're sending to insurance companies, that's money they cannot give their workers in raises. They need to understand that. And they need to understand that they've been taken to the cleaners for years and years, that they're wasting money. So much of what we spend on healthcare does not go to improve somebody's health or get someone well.
The problem of price gouging and irrational price variation is absolutely rampant. And it only takes one look at a hospital price file to know that there is no logic other than revenue extraction.
What an employer or an employee calls premium, a health insurance company calls that revenue. Who wakes up in the morning wanting to lower their revenues? Nobody. The whole system is built incorrectly. Everybody in that food chain makes more money when costs go up. The health insurance company does, the broker does. If you make commissions, I make commissions off of premium. Premiums go up, I make more money. Hospitals need to fill beds. Doctors get paid more the more services they do, the more prescriptions they do.
And it doesn't have to be that way. There's a solution. We've been solving this problem for 20 years.
We will charge what the market will bear. Now, the problem in healthcare is that oftentimes there is no upper ceiling to what a life can be worth.
But why would otherwise savvy business leaders who ruthlessly manage the cost of every other purchase their company makes overlook, ignore what has become their second or third largest line item on their P&L? It's because of what I call healthcare's big lie. The lie is simple. You can't control the cost of healthcare.
We realized we can charge a tenth of what a so-called not-for-profit hospital charges and still be profitable.
Often it's just unquestioned. And these companies are leaving a lot of money on the table and getting ripped off in many ways that just don't acknowledge.
It's one thing to produce a widget, it's another thing to engage in the health and well-being of your workforce, because it's life and death. Hello, test, there we go. Welcome to the 2024 NextGen Healthcare Summit. This is part one of two for this year. What you just watched was a trailer to the new documentary. It's not personal, it's just healthcare, which our firm is proud to be producers for the film. It will be released hopefully by the end of this month. You saw April 2024, and even talking to the director, he was like, you know, it will at least be ready by April 45th. So it will be coming out very soon, and you'll get some information on where you can watch that. But we're really, really excited. And that film is really positioned to educate employers, business leaders around what's going on in healthcare and how it impacts them, but also how it impacts their workforce, and to illuminate how much opportunity or control that they have in potential change and real change. Another thing I think I found interesting as we went through this, in our field, as you guys know what we do from an insurance agency, but specializing in employee benefits, commercial and personal. Sometimes I come home at the end of the day and share with my wife the things that are going on. And as you can imagine, she has very little interest in that. Very little interest, but we actually walked through more of an extended cut of the film. And she goes, now that is actually pretty interesting. So maybe there's some hope to the larger American public, just to educate of what the system is doing. But you are in for a treat today. We have some incredible content around population health. We also have a keynote from one of the experts in the documentary to talk about the healthcare system at large. But before we continue, I want to give a big thanks to our sponsors that help finance this event and make this possible, and our title sponsors, specifically Imagine 360 and TrueRx. So a big hand to them. And then we have our advocate sponsors that are Delta Dental, TPAC, RX Help Centers, Stealth Partners, Unified Group Services, and Wellbridge. And if you listen closely, we just named several organizations, and quickly, I refer to that as like the cheat codes of a health plan. If you want to really look at doing healthcare different in a way in which changes the game and allows you to invest more in your work, in your workforce, these folks can help you do that. So we're about to get started. I wanted to invite Deanna Miller to get this thing kicked off, as she has been the grand master of ceremonies and getting us all organized today. So a big round of applause for the work she's done for this event.
Good morning, everybody. It's nice to be here. So first of all, we're going to kicked off with Chris Schubart, one of our title sponsors. He represents Imagine 360, and I'm sure some of you are familiar with who Imagine 360 is, but they deliver a customized solution that completely reimagines the healthcare experience for self-funded employers and their members. Their full-service health plan solution is a better choice for employers who are determined to escape the high cost and inflexible models that dominate the market. There we go. Leveraging 50+ years of experience, Imagine 360 combines the financial benefits of reference-based pricing with best-in-class member support and plan administration services. Guiding members through all phases of healthcare, a specialized team offers care navigation and clinical support and relentlessly advocates for members to receive quality care at an affordable price. So we really, truly thank Imagine 360 for being a title sponsor. And I have Chris Schubart, Director of Business Development, with us today to tell us more. Come on over, Chris.
Morning, everyone. Everybody doing good? I was going to add this really kind of long intro. The trailer, though, is awesome. Is anybody here? Everybody being here, I'm guessing you're kind of forward thinking and you're at least curious about the current healthcare system of today. Does anybody think it works? No, right? You pay more and you get very little value out of it. Does anybody think healthcare is actually improving the health of your employees today? I didn't think so either. So I didn't think those were big, wimpy limbs to walk out on them when we talk about what we do. You're going to hear a lot of things about population health today, which is incredible, because where that comes into is really making a difference in the well-being of your employees, the actual health, improving their health so they live more productive and happier lives. Incredibly important stuff. Imagine 360, we can contribute to that, but honestly, we're the other side of the equation. We're the unit cost side. All right. So any CFOs in the room, I know there's at least one. And at the end of the day, it still comes down to counting the beans And today we're paying way too much for the unit cost of healthcare, as also mentioned in the trailer there a moment ago. And in the Imagine 360, by the way, our crack marketing department, when they named the company, they broke rule number one, which is give some idea what you do. Imagine 360 tells you nothing. So what we are, in essence, is an integrated health plan that uses reference-based pricing and direct contracts to allow you to access care at a greatly reduced price from what you're paying today. So, for example, in Indiana, if you were going to have a CT scan or an MRI, something like that, you're probably going to get charged around $2,000, roughly, give or take a couple $100. Your insurance company is going to give you probably half to 60% off. So you're going to pay roughly $900 to $1,100 for that CT scan. The actual scan costs about $50. That's the actual markup, $50 to $1,100. That's incredible. Now take it again a little bit different way. How many CT scans are done? Literally hundreds of thousands are being done in Indiana today. So it's millions and millions of dollars that are inflated by many times 1,000 to 2,000%. And that's just the reality. And we was talking about before, the market will bear the price. The elasticity point is because most of your employees are insulated from the cost of care. And the reality is data is the secret, right? And so with Ben and the Connor team, what they do is deploy partners like ourselves, like TrueRx, like Wellbridge Surgical, to pull back and show you the data. And so that's incredibly important. So in Imagine 360, at the end of the day, we serve more than 50 clients here in Indiana, roughly 17,000 employees here in Indiana, over 600,000 employees nationwide. We have employees and companies in all 50 states. We've been doing this for 18 years. So as a reformed healthcare executive for two of the big insurance companies and one pretty large regional healthcare system, I can honestly tell you, I thought all along I was on the right side of the equation until I saw both sides of the equation. The reality is the game's rigged against you. And I don't mean negative. There's answers. There are answers today. And I think we, check with the Connor team to get with us. If you're curious, I hope you're curious. And I thank you for your time. Appreciate you being here. Appreciate you being curious to learn more. That's really is the beginning of making change in this country, because it's up to the employers to do it. There's no incentive for hospitals, no incentives for insurance companies, and frankly, no incentive for the government. Too many lobbyists. You go down the lobbyist list of who's got the most money. It's primarily healthcare who's contributing. So there's no incentive for that to change. So it's you guys who hold the keys to all that. Thank you for your time. Enjoy the day and appreciate your time.
Thanks, Chris. All right, it's my honor to introduce our next speaker. Nelson, I don't know if you know this, but right when I joined the benefits industry was right before I went to a conference down at Ascend. And man, I left that conference just enthused to change healthcare. And so we're excited to have you to share about that. So Nelson's a controversial visionary, best-selling author, in-demand keynote speaker. He's the chairman of the NextGen Benefits Network, a national alliance of independent healthcare advisory and consulting firms. His members are revolutionizing healthcare benefits, healthcare delivery by helping executives improve both the cost and quality of healthcare. The success and strategies have been featured in prominent business publications, including Chief Executive, Employee Benefit News, and CFO. He's an authority and popular speaker on private sector healthcare reform. He's addressed audiences in 46 states and the District of Columbia, as well as keynoting numerous conferences. Before benefits and healthcare, he had a distinguished career as a nationally recognized public policy expert, served as president of 2 public policy think tanks promoting a free market and limited government agenda, and testified before legislative committees, received appointments for several influential commissions, also had a radio show as the host of a morning talk show and popular jazz music program. Graduate of Tennessee, he and his wife Elizabeth live in Nashville. have 2 grown-up children and a beautiful baby granddaughter. Happy to introduce Nelson. Nelson, good job.
What you don't know about healthcare can kill you. All consumers want from their healthcare, and that includes you sitting in this room, those of you who are employers paying for healthcare for your employees and for your employees. All we want from healthcare and from our health insurance, 2 things. We want high quality care that we can afford. Isn't that it? Doesn't that boil down to just that? Now, price is what gets the conversation. And so I appreciate what Chris was just saying about price, because it gives you a sense of the problem with price in healthcare. What we do know about price in healthcare is that every year since 1960, healthcare costs have gone up. And since 1999, employer premiums for health insurance have more than tripled. Sitting here talking to a group of employers about healthcare reminds me of the best way to boil a frog. Now, if you boil a pot of water and you take a frog and you toss the frog in, the frog will jump out. But if you put the frog in a pot of cool water and then turn the heat up, the frog will sit there, getting warmer and warmer, but won't jump out, and will sit there until he's cooked. That's the best way to boil a frog. Those of you who are using traditional healthcare are a bit like that frog. Now, I call this the employer healthcare hot tub, because it feels kind of comfortable. You're familiar with it. It can be sort of toasty, but do you expect the temperature to go down? Do you see the situation improving? Because it doesn't end well for the frog. But I'm not here to talk about price. I want to talk about what we generally don't discuss in healthcare, which is quality. Quality in healthcare is critical. A friend of mine, Leah Bender, at the Leapfrog Group in Washington, that grades hospitals on the quality of care, the safety, has said famously, there is no good price for bad healthcare. We agree with that? Sure. I don't care how cheap it is. If it's bad healthcare, I don't want it. Who does? So I want to talk about 2 aspects of healthcare quality: medical misdiagnosis and physician quality. Let's start with medical misdiagnosis. This is extremely common in the United States. In fact, a very, very common procedure, heart stents, is misdiagnosed a lot. Anybody want to take a guess at what % of heart stents are misdiagnosed? In other words, they should not be installed in the patient. Really? How? 60%. Most people go 20%, 10%. I've got experts in the room. Thank you. You're absolutely 60%. 60% of the time, patients who get a heart stent don't need it. It's misdiagnosed. Spine surgery. I'm not even going to ask this time. Spine surgery, 55% of spine surgeries are misdiagnosed. They should not be done. 1 in 20 Americans experience a misdiagnosis every year. That's around 12 million people. And half of those misdiagnoses can be harmful to the patient. Let me mention an example or two. This is Lenox Hill Hospital in New York City. By the way, do you have any hospitals here with a doorman? What does that cost? But there was a woman named Eugenius Rodriguez who had a lump in her breast, and so she went to Mount Sinai Beth Israel Hospital in New York. She met with Dr. Jean-Marc Cohen, who diagnosed her with breast cancer, and he sent her to Lenox Hill for a mastectomy. Which is unfortunate, because Lenox Hill just took Dr. Cohen's diagnosis and acted on it. But it was a misdiagnosis. She had no cancer, but she did have a breast removed. As I said, these misdiagnoses can be harmful to the patient. University of Kansas, a young housewife named Wendy Berner, mother of a few kids, didn't feel well, so she goes to the hospital and she meets with Dr. Meenakshi Singh, who runs the pathology lab, and does a biopsy, and the diagnosis is pancreatic cancer. Fortunately, after she was announced cancer-free after surgery that removed part of her pancreas and part of her some other body parts. But this is no great feat, being told you're cancer-free, when in fact it was a misdiagnosis. She did not have cancer to begin with, and the surgery was totally unnecessary. No cancer. Cancer, in fact, which is one of the most serious diagnoses, I think we can all agree, is misdiagnosed almost a third of the time. And sometimes they're not as fortunate as these patients. This beautiful 12-year-old, Alyssa Alcaraz, wasn't feeling well. Her mother took her to an urgent care in California, and the doctor examined her and said, "You have the flu. Go home, take some ibuprofen, and rest for 7 to 10 days, don't go to school." So she did. 4 days later, she died. From the flu? No. The diagnosis was the flu, but in fact, it was a misdiagnosis. She had sepsis. Her body shut down. Had a heart attack, actually, at 12, and died. Totally unnecessary, because all the doctor had to do was send the blood test to find out more, but he assumed the flu. Vibrant young man, 36-year-old Evan Kennedy, wanted to run a marathon to raise money for a charity. But he was concerned because he had hereditary heart issues. So he goes to his primary care doctor and says, "Can I run? Can I do the training to run this marathon?" And the doctor says, "Yes, you've shown no symptoms whatsoever." So he begins training. And a couple of days into the training, he's walking back to his car with some friends after the run, and he drops dead in the parking lot. It was a misdiagnosis. She should have sent him to a specialist. She did not. And as a result, he died. His father said, well, she said he'd had no symptoms, but the symptom he had was he died. Tragic. 370,000 people a year die of misdiagnosis. 1 in 5 hospital deaths are due to misdiagnosis. Most of you will know of Mayo Clinic. It's one of the premier medical institutions in the country, not the world. Mayo Clinic realized, the leaders at Mayo Clinic realized, we only do second opinions. Nobody comes to Mayo Clinic for their health care. They come after they've been diagnosed back home, and they come to Rochester, Minnesota, to Mayo for the best health care. But Mayo doesn't just take the doctor's word, they re-examine the patient and provide a second opinion. And so Mayo wanted to do a study, which they did, which has been published in a peer-reviewed journal. They asked two questions. What percent of the original diagnoses we get do we uphold 100%? Absolutely correct. The doctor is correct on the diagnosis and he's correct on the treatment. Because if the diagnosis is right, the treatment's wrong, patient's not going to get better. And what percentage of original diagnoses do we find to be 100% wrong? In other words, the diagnosis is wrong. Because if the diagnosis is wrong, it doesn't matter what the treatment is, you're treating the wrong problem. So they did a study. You can't answer this. But anybody want to guess what percentage of original diagnoses were found to be 100% correct? 50%, 60%? Anybody want to guess? How much? Do you work with him? 12%. 1 in 10 doctors get the diagnosis and the treatment recommendation correct. 1 in 10. Now, how do you feel about your doctor? 1 in 10. So, what about those that are 100% wrong? 3%, 5%, 21%. Remind me not to ask your audiences any more questions. 21%. That's 1 in 5 diagnoses that are 100% wrong. How do you feel about your doctor now? This isn't a criticism of any individual doctor, but the statistics, the data speaks for itself. So the solution to misdiagnosis is pretty obvious. What does Mayo do? They provide a second opinion. The solution to misdiagnosis is an independent third-party medical second opinion. Ronald Reagan once said about the Soviets when he was negotiating arms reductions, someone said, do you trust the Soviets? He said, I do. I trust and I verify. So I trust my doctor, but I'm going to verify that my trust is correct. Independent third party. What I mean by independent third party is it's not the surgeon down the hall in the same practice. This is you need a surgeon, a doctor that has no dog in the fight. He's no connection whatsoever to the original physician. Second opinions are critical because what you don't know about healthcare can kill you. So my question for you is, does your healthcare plan, does your insurance company require independent medical second opinions for serious conditions? I'll save you the trouble of thinking about it. The answer is no, they do not a single one. Why? I don't know. It's such an inexpensive way to confirm that, yes, you're being treated properly. But there's also a price issue involved. When the most expensive claim that your health plan will ever get is the one that shouldn't have happened. The open heart surgery that shouldn't have happened, the spine surgery that was unnecessary, the stent that wasn't required, the cancer surgery and chemo and radiation that wasn't necessary because there was no cancer. Fortunately, in addition to the major insurance companies, you have options. At Connor, they do something called NextGen Benefits. And NextGen Benefits is not a health plan, it's a model. It's a new and innovative model for employer-sponsored health plans. But what's so great about it is it, for the first time, gives you control over not just the price, but the quality of the healthcare you're providing your employees. And there's nothing rocket surgery about it. It's using standard business practices you're using in every other business unit in your company. You can talk to them about NextGen benefits. The important point here is NextGen plans do generally require independent medical second opinions to avoid the misdiagnoses, not just the human cost of someone being treated that doesn't need it, but the financial cost to the plan as well. As medical misdiagnosis, it's incredibly common and it's incredibly tragic and very expensive. But let's look at physician quality. This is tautological. Of course, not every doctor is created equal. I was doing some research and was reading a journal article in a peer-reviewed medical journal, and the title cracked me up. The title was half of all doctors are below average, except in Lake Wobegon. Well, of course they are. Again, tautological. Yes, half of doctors are below average. The question the article was asking is, who wants to go to a doctor that is below average? Don't we all want to go to the top 25%, the top 10% of doctors when we're sick or our loved one is sick or hurt? So I'd like you to take a look at these 5 surgeons. Tell me which one has the best medical outcomes. Not the best bedside manner, who cares? Not the best social scores on Google reviews. Who has the best medical outcomes? Who can tell me? Not even you, sir, can tell me. And yet, if you want to keep your water running, if you want your house to look fresh, if you want your electricity going, your lights on, these service providers, you can look up all sorts of information on the quality, the reliability, the dependability of service providers, whether it's Angie's List or Thumbtack or Home Advisor. You don't have to operate blind in terms of who's going to fix your house. But isn't your health a little bit more important? Who do you go to? Where do you turn? How do you know who the top doctor is? You can't. So let's do a little experiment. Let's say that we go to the doctor. We're having some issues, and we go to the doctor, and the doctor diagnoses us with ureteral blockage. This is a blockage of the ureter, which is the tube between the kidney and the bladder. Now you've got 2 kidneys, so you have 2 ureters. But the solution is surgery that puts up a mesh tube called a stent into the ureter to get rid of the blockage. Now I'm from Nashville, and I need somebody to do this surgery for me. So I looked up and found Dr. Kelvin Moses, just a real doctor in Nashville. Not only is he a doctor, he has his doctorate, his PhD. So he's a very learned individual. He's a urologist. This is who would do the surgery on your ureter, on our ureter. But what do we know about him? Well, what are his credentials? Well, first of all, he's an associate professor of urology at Vanderbilt Medical School, which is one of the top medical schools in the country. He is also the fellowship director for the Urologic Oncology Fellowship. And he practices at Vanderbilt University Medical Center. For you in Indianapolis, think IU Medical Center, the premier academic teaching medical school. His education, he graduated from Baylor Medical School in Texas. He did his residency at Emory School of Medicine, fine medical school in Atlanta. And he did his fellowship at the very prestigious Memorial Sloan Kettering Cancer Center in New York City. Pretty impressive. He is board certified in urology. Not all urologists are board certified. He is. He's also written academic publications, not surprising given he's a PhD. He has over 15 peer-reviewed academic articles in journals. And If you want to see his social scores, there they are. U.S. News and World Report, 5 out of 5 stars. Excellent. Google reviews, 5 out of 5 stars. Excellent. Who here would go to Dr. Moses? I would. Wouldn't you go? Is this not pretty compelling? Carla Miller, West Tennessee, was diagnosed the same thing we had, just coincidentally. She had a blockage of the uterus from the left kidney to the bladder. Surgery put in a stent from the left kidney to the bladder. She turned to Dr. Moses at Vanderbilt University Medical Center, and he did the surgery, which didn't turn out so well. He and the other surgeon operated on the wrong kidney. They went from the right kidney through the utera to the bladder, which the problem was there was no blockage there. So she had to undergo another surgery to remove that stent and implant the one that belonged going from the right to the left. Now, you could say this is an honest mistake. Good doctors make honest mistakes. This is known, by the way, operating on the wrong organ, the wrong side of the body, the wrong leg. It's known as a never event in hospitals, as in this should never happen, but it does. But it's honest mistake. Good doctor, honest mistake. But I want to introduce you to something called Quantros. Quantros is a data analytics system that provides insight into the medical outcomes of doctors, primarily surgeons. This uses the data, outcomes data submitted by doctors to the centers, Federal Centers for Medicare and Medicaid Services. If you want to get reimbursed by the federal government for Medicare and Medicaid, you have to submit your outcome scores. So doctors do. Falsifying those outcome scores, by the way, can land you in prison. It's a federal crime. So they tend to be pretty accurate. Quantros doesn't just use 175 million encounters surgeons to patients, but they also do what's known as risk adjustment. So let's say you've got 2 brain surgeons. One brain surgeon works in the emergency room and he treats patients who have head trauma from car wrecks. That's a different proposition altogether, isn't it? From treating a patient who walks into your office and says, "Doctor, my head hurts," and you do brain surgery on that patient. So they do what's known as risk adjustment, so you can compare Dr. A and Dr. B, even though they have substantially different operating and patient situations. This is so reliable that over 800 hospitals and medical centers in the United States rely on Quantros to evaluate their own doctors. So I thought it'd be interesting to take a look at Dr. Moses' Quantros score for the clinical category of overall surgical care, which seems to be applicable here in the case of Carla Miller, where the wrong kidney was operated on. So what was his Quantros score? Oh, the 16.4. Now, that's not a 16.4 like you would get on a test. It's not an absolute score. It's a relative score. What this means is Dr. Kelvin Moses has worse outcomes than 83.6% of urologists. Only 16.4% of urologists operating in the United States have worse outcomes than Dr. Moses. I'm sorry, he's a bad doctor. You can't get around it. He's a bad doctor. When you go to Blue Cross of Tennessee's provider directory, there's Kelvin Moses, specialty urology, but there's a warning. This is a dangerous doctor. Be careful. No, there's not. I put that there. But shouldn't there be something like this? Just a little homage to the classic TV show Lost in Space. There's no warning whatsoever. No guidance, no reason for you to think that Dr. Kelvin Moses is anything other than what his credentials would tell you is great doctor. Why not? I don't know. So how would you know who the top doctor is? By the way, Carla Miller at 48 died of heart problems a few months later. Her doctors said that it was a result of the misdiagnosed surgery, the unnecessary surgery. What you don't know about healthcare can kill you. But let's take a look at another doctor. This is possibly one of the most highly qualified physicians I could find. He's chief of the thoracic and cardiac surgery. This is at Brigham and Women's Hospital in Boston. Very prestigious. Co-director of the Lung Center, vice chairman of surgery for cancer, distinguished chair in thoracic surgery and lung cancer research, and he's a professor at Harvard Medical School. Surely we can rely on that. What's his Quantro score? Clinical category of overall hospital care, not surgical care, it's a mistake. Overall hospital care is 6.8. Only 6.8% of thoracic surgeons in the United States have worse outcomes than he does. But you wouldn't know it from his credentials. By the way, look at complications. Only 0.1% of thoracic surgeons in the United States have fewer complications than he does. Readmissions, only 21.9%, 22% have worse readmission problems than he does. By the way, complication means he makes a mistake, just like Dr. Moses did. Oh, wrong kidney. Got to do it again. By the way, who pays for that next surgery, that second surgery? Does the doctor pay for it? No, the plan, your plan pays for it. The readmission to the hospital is a result of the complication. Does the hospital pay for it? No, your plan pays for it. But the good news with Dr. Bueno, he doesn't kill many of his patients. No bueno. This is a Massachusetts Blue Cross. There's Dr. Bueno's listing. Do you see any warning? No. Why not? I don't know. This is a personal story. This is my friend John from Pittsburgh. John is a work friend, a work acquaintance. We've done some business together. And I called him one day about a project. And I said, John, what's going on? He goes, oh, yeah, you know. So what's going on? Personal health issue. John, what's going on? He hesitated. And then he said, brain tumor and brain lesion. Brother, I'm so sorry. Gosh, how long have you known? Not long. I said, prognosis? He said, too soon to tell. I just did my first MRI, but I feel really good about my medical team there at UPMC, University of Pittsburgh Medical Center, which is highly regarded. I said, well, that's fantastic. Good. If you want to give me the name of your brain surgeon, I'll run him through our Quantros program that I have access to only because we work with a medical utilization management team. It's like $36,000 a year for access to the Quantros system. I don't have that, but I have access through this strategic partner of ours. John said, you could do that? Yeah, absolutely. So he gave you the name, Dr. Georgios Zanonos. So Georgios Zanonos, assistant professor at University of Pittsburgh School of Medicine, neurological co-director, Center for Cranial-Based Surgery, director of clinical operations at the UPMC Presbyterian Hospital, co-director, neurosurgery, skull-based fellowship. Graduated very high in his class, University of Athens School of Medicine in Greece, did his residency at UPMC in Pittsburgh, did his fellowship at Harvard Medical School. He's board certified in neurological surgery. And he was honored 4 different years with a very prestigious Copeland Award for cranial research. So he does good academic work. And he practices at University of Pittsburgh Medical Center. So I had Dr. Zanonos run through Quantros. This is his score, the clinical category of neurological surgery, brain surgery. This is what he does. This is what John was going to need him for. If it were out of 10, it would be pretty good. But it's not. It's out of 100. And he scores a 9.5, which means that 90.5% of brain surgeons in the United States have better medical outcomes, surgical outcomes, than Dr. Zanonos. Look at his mortality score. Very poor. Complications, very poor. Readmissions, very poor. Patient safety, poor. He's a bad surgeon. John said, in 30 minutes, I went through every phase of grief over these numbers. Don't get me wrong, he said, this is so helpful. You said you had good news and bad news. What's the good news? I said, I'm sending you the names of 10 Pennsylvania brain surgeons who have scores above 95, quality outcome scores above 95. He picked Dr. Evan Marlin. But Dr. Evan Marlin, 99.7. And look at the various categories. Great, great brain surgeon. But Giorgio Zanonos is not. And when you go to his Blue Cross page on the directory, where is the warning? Why not? He's a dangerous doctor. Would you want to go to Dr. Zanonos? Would you, Zanonos, no bueno. They don't, why, that guy didn't write this. Can't make this up. So the top doctor, shouldn't you know? Don't you deserve to know the quality of the doctors that you're going to choose? Because what you don't know about healthcare can kill you. When the insurance company sends you to their directory to select a doctor, and let's say you type in brain surgeon, pretty serious time in your life. Yes? When you're sent to the directory to choose a doctor without any information about the quality of that doctor's outcomes, without any guidance around the quality of the doctor, you are being forced to play a very dangerous game of healthcare Russian roulette with your life and your health. Maybe you get an exceptional doctor. Click. Maybe you get Dr. Zanonos. And you don't know until it's too late. You don't know until you or a loved one has a complication, doesn't make it through surgery. The wrong side of the body is operated on, the wrong organs operated on. Does your insurance company provide you with guidance, information about the outcomes quality of the doctors and hospitals in their network? No, not one. Not a single one. NextGen health plans do. NextGen style health plans not only give the member information and guidance around the quality of the doctor, but most of the plans will actually reward the patient for using the high quality doctor and the safe hospital by waiving their out of pocket. In other words, their health care is free, as it should be, because they're going to a high quality doctor that's not going to create a complication, not cause a readmission. They're going to get the job done right the first time. This issue is so critical, quality in healthcare. This is why Ben and Ryan at Connor are co-authors of the Amazon best-selling book, Life and Death Decisions in the C-Suite, which is about the quality of care, not just the price of care. This is available on Amazon, but if you ask them nicely, I bet you can get an autographed copy for free. So we've talked about quality. Price is important too. But if you're sitting in that hot tub, you don't have any information on quality, no guidance from your insurance company. Your price is going up every year, regardless, by the way, what your plan does, utilization of healthcare. You could just sit there and see what happens. But we all know a definition. Doing the same thing over and over again, expecting different results, is the definition of insanity. What you don't know about healthcare can kill you. Don't you need to find out about your doctors, about the hospitals? There is an option. You aren't stuck with the same old, same old. So as you sit there in that employer healthcare hot tub, isn't it time you try something different? I invite you to. Thanks so much.
Thank you, Nelson. Now that we are all terrified and going to go Google or try to research our physicians so we don't die, I want to introduce you all to our next speaker, Eric Barker. He is with TrueRx. TrueRx Health Strategist is led by a fourth generation of pharmacists. They are family owned and continue to provide caring service for clients and patients. Their team of pharmacists and strategists deliver proven programs that find maximum savings and minimum disruption by creating a benefits plan that fits the unique needs of clients and patients. Eric Barker is the Chief Growth Officer for TrueRx Health Strategists. His expertise in pharmacy benefit strategy and solutions is informed by a career in clinical pharmacy. He also worked in pharmacy services management. Eric has been a multi-state licensed pharmacist for over 20 years. He was board certified in geriatrics and psychiatric pharmacy, in addition to several clinical operation roles. Eric serves as a member of a pharmacy and therapeutics committee for a long-term case pharmacy that provided medication guidance for over 100 pharmacies across the country. He is a graduate of University of Toledo College of Pharmacy. We thank TrueRx for being a title sponsor today. And I will hand it over to Eric.
All right. Those introductions are always uncomfortable for me, right? I'm like, I'm a pharmacist. It doesn't matter what my fancy title is or what I do. And Ben always looks forward to this talk because I always put pharmacy stuff up that he really likes. Sometimes pictures of molecules. We got graphs today, Ben. So last week I was at the the Association of Managed Care Pharmacists. So these are pharmacists who work for PBMs. They work for big carriers. Lots of students there. So I looked at over probably 200 posters of students putting things out there. Probably 40 of them were on GLP-1s. It was the hot topic of conversation. There was not one talk that I attended, and I was in educational sessions from 6:30 in the morning until about 8:30 every night. A lot of CE, so that was good. So what we're going to talk today about is I'm going to give you some background about GLP-1s. Much like Nelson did, I'm going to try to flip your thoughts on those around a little bit. And really, that's what we do at TrueRx. Our official name is TrueRx Health Strategist. That's not a tagline. You're going to need strategies for what's coming. If you think weight loss is the only issue with GLP-1s, You are mistaken. There's one of the hot topics last week was something called MASH. There'll be a spelling test on this later. MASH stands for metabolic dysfunction associated steatohepatitis. It's a fancy way to say you get fatty liver disease and you get hepatitis. Remember a few years ago when we had all those commercials that said, now's a good time to ask your doctor about hepatitis C? They were advertising a $95,000 medication for 12 weeks of therapy. 25% of the people in the country have fatty liver disease. 5% will develop MASH. Guess what treats MASH? Nelson, you can answer this one. GLP-1s will be a great solution because they have really good data for fatty liver disease. Chelsea Journal works for TrueRx. She's a board-certified ambulatory care pharmacist who specializes in diabetes care. She's awesome. She's my expert that I talked to. We were at this together. We had a lot of fun together. We also learned a lot, kind of split where we were going and came back and said, what did everybody talk about? MASH, GLP-1s, weight loss. So GLP-1s, let me be honest. They are fantastic medications. As a pharmacist, and Aaron Searles, I see back there, also another pharmacist with TrueRx, we can tell you these are life-altering medications when used appropriately. The data on them is incredible. I just read a study a couple weeks ago about women who suffer from PCOS, which is something that they struggle to get pregnant. There's a new phrase. It's called Ozempic babies. Women who are told you'll probably never have a child having babies. How life-altering is that, right? These are great medications with wonderful side effect profiles. They have side effects, but we're going to really talk about obesity today. 70% of Americans, 70% are obese or at least overweight. It's a lot of people. You can get metabolic syndrome for that, increased blood pressure, elevated blood sugar, abnormal cholesterol. None of those things are healthy. None of those things are good. And then your risk for heart disease, type 2 diabetes, stroke, mortality rises. So you get all these things that come from being overweight, and then you got to hope you can find the right doctor that doesn't make that worse. Graphs, Ben. I like graphs. The financial impact. It's expensive to be overweight. There's a fancy way to say that. People don't come into work as much. They get sick more often. They have more medications they take. There is nothing positive about being overweight. My brother-in-law, and I asked his permission to talk about this, is morbidly obese. He weighs over 300 pounds. And he came to me a couple years ago and he was talking. He goes, so how bad is this? My doctor said to me, you're the healthiest fat guy I know. What do you think about that? And I said, you need a new doctor. There's no such thing. This isn't good for you. This isn't helping. And 2 years later, he's having profound health issues, and they are tumbling one right after the other, including getting a stent put in his ureter a couple weeks ago. That's not going very well, by the way. Relative reduction of disease. If we can get 5% weight loss, you can see across the board, we can lower the risk of type 2 diabetes, hypertension, coronary heart disease, heart attack, stroke, and all-cause mortality. Obesity is a problem in our country. You get a 25% weight loss, you've changed a patient's life. Change the patient's life. You give them a chance to live longer. GLP-1 medications have been around a long time. Actually, the first one came out in 2005. Victoza came out in 2010. Semaglutide, which is Ozempic, was the best that we had by far. Amazing medication with amazing studies came out. Started to see the weight loss thing. And then, of course, we've got, all these other medications. Saxenda came out, wasn't so good for weight loss, but that's all it was for. Wegovy. And now we have Mounjaro, which is made by the local pharmaceutical manufacturer. And then their version of Wegovy, the Mounjaro is for diabetes. Zepbound is their weight loss medication. Okay, we'll see who can get. You got to ask harder trivia questions or harder questions of the audience, Nelson. Does anybody know Which, I'll even give you a little hint. Which animal led to the discovery of GLP-1s? Yes. Gila monsters. Gila monsters eat once a year. And we figured, scientists were studying and say, why do they have to do that? Turns out this little peptide they have allows them to store a year's worth of food in their tail. And so somebody said, let's study that and see if it helps people. It helps people. Glucagon-like peptide 1. Saxenda, 9% weight loss. Most of those people are still sick enough to go back into the study. Not very helpful. Wegovy, up to 17% studied. I will tell you, patients who stay on Wegovy will continue to lose weight past 17%. And Zepbound or tirzepatide, which is the local product, studied up to 22.5%. Again, patients will continue to lose weight beyond that. They need to be taken consistently. You can't just go, well, this week, I want to eat really, I'm going out for pizza, I'm going on vacation, I want to have a couple extra rum and cokes. Not a good idea. If you're on them, you're on them, stay on them. A few doses or inconsistent doses sometimes will cause people to have to go all the way back to the titration, which right now is exceptionally difficult. We're having massive shortages of these medications that the FDA has said will last through the second quarter of this year. We also, by the way, have the worst medication shortage problem we've ever had in our country. It's not just GLP-1s, it's across the board. We are struggling to get medications to patients, including medications we use to treat pediatric oncology. Can you imagine being a hospital pharmacist or a physician going in and saying, we got a treatment, we just can't find it. It doesn't exist. So this is a really important thing. So 68% of patients taking GLP-1s stop within the first year. Some of that, frankly, is due to the fact that they've hit their goal weight. Some of it is due to side effects. Some of it is due to the fact that people don't like injections. Some of it is due to insurance coverage. There's a lot of reasons. It's not just, oh, it's a horrible drug, it makes you really sick, and so people stop it. That's not the case. There's a lot of different things. Every medication is a tool and nothing more than that. If you have high blood pressure and you have 4 pieces of bacon for breakfast and you put salt on it because, darn it, it just tastes better with salt. There is no point in taking your blood pressure medication. You are fighting the tool that is the medication to help you, right? If you keep smoking and 5 minutes later you use your inhaler, there's not logic to that, right? You got to stop smoking if you have COPD. GLP-1s are a tool to help people lose weight. And this is one of the first take-home messages I'm going to give you. Whether you're an employer, a TPA, benefits broker, Nelson advises a ton of people. This is key. You spend money on healthcare as an employer. You need to change that thinking and invest in the health of your employees. And the first way you do that is if you're going to cover GLP-1s, and I'm going to explain a little bit why you're going to have to sooner than later, whether you want to or not. If every 20 people is $250,000 in drug cost. Every 20 people, $250,000 in costs. Why would you not go hire a Weight Watchers coach for $40,000 a year? Why would you not get a really talented nutritionist to come in and teach your people how to eat properly? Why would you not put, Forrest is out there, Forrest works at Unified. They put a gym in their offices a few years ago, right? Private rooms, it's awesome. People use them all the time. I call Forrest all the time, what are you doing? Got my workout time scheduled, right? They invested in the health of their people. That's what you're going to have to do as an employer with this stuff. You're going to have to control and make sure that the medication is a tool to help people change their lives. Strategies for employers. Utilization management. This is prior authorizations that work, not just, hey, we've checked a couple boxes as a PBM, Optum and the big ones. They can make money by more medications. These are highly rebatable medications. So if your PBM keeps the rebate dollars, they love these. They're going to encourage you to put them on formulary because the PBMs, the traditional PBMs will make more money. If your PBM gives the rebates back to you like we do, that's a great thing. It will help offset the costs, but it will not completely eliminate the cost, and that's important. So making sure utilization management, maybe the prior authorization says, we've hired a Weight Watchers coach, you must attend 80% of your scheduled meetings. Maybe it says you need to have certain comorbidities, you must sign up for something. As in a self-funded employer, you have control over these things. A health strategist will work with you to come up with something that works for you. At TrueRx right now, one of the things we've got Chelsea doing is working on a checkbox so that we can sit down with an employer, and Ben and I could be in a room and say, okay, here's what we think at a minimum you need on the PA. If you want to tighten some things up, let's add these other things. And what are you doing to help your employees and invest in them? Let's add that as well. You're going to have solutions. Enrolling people in continuous diet, exercise, lifestyle programs. If you're an employer and when you start covering these, you don't include that in your prior authorization, you're failing your employees. You're giving them a medication without giving them the tools to be healthier. And again, continued coverage has to be on outcomes. If a patient comes to us and has rheumatoid arthritis and the doctor has prescribed Enbrel and it's clinically appropriate, we're going to put a prior authorization for a year. That's not going to change, right? We think on these medications, we're probably going to put the first prior authorization for no more than 6 months because we have to make sure the patients are losing weight. You can eat through this. It is very uncomfortable to do, but we have diabetes patients for years who are gaining weight on these. Like, how are you doing that? My gosh, you must feel like you ate 3 pizzas for every meal. Medication doesn't work. It does. Patients are eating through it. So making sure that we're checking outcomes, patients are doing it. The other outcome we fear is patients losing weight too quickly. That's a problem. That leads to gallbladder dysfunction. That leads to a lot of things. Leads to people being skinny fat. So their body fat percentage stays the same. They're just muscle wasting because they're losing too quickly. We don't like that any more than we do gaining weight. They're equally bad. So again, what can you do? Get access to health strategists, whether it's a good brokerage team, whether it's a good TPA, good PBM, health advisors. Weight Watchers is an amazing program. There's a reason I mention it. The little app that tells you, you're a purple, blue, green, I don't know what their colors are, but you can live a normal life. Like you can go out and have dinner and have a couple glasses of wine tonight because that's what you want to do. You just balance it, right? Getting a nutritionist, get access to those people, invest in the health of your employees. Be proactive because I'm going to show you why these things are coming. You're not going to be able to avoid them. And explore lifestyle disease state education. This is the thing. Everybody knows that when they're overweight, they don't feel well. A year and a half ago, I was at a weight I'm not even going to mention. I'm embarrassed. I let myself get there. There's no excuse. And I'm losing the weight now. Hit a really good number this morning. I was excited. No, don't clap because I put myself in that situation. Thank you, but no, that's not what I'm looking for. I feel a million times better. My energy is up. My mood is up, right? I didn't realize, and my doctor was laughing at me. He goes, yeah, you have labs and your heart sounds like you're a 20-year-old. And I'm like, yeah, it won't last. I've got a good constitution. I'll last a little longer than most, but I wasn't feeling well. It wasn't any fun. I knew I had to be here early. I got up at 5 this morning, got a little walk in, right? Because I needed it, because I felt like it. Help your employees get that point where they crave a good lifestyle. Ben and his team, what can you guys use to grow? Be informed, offer solutions for your employees. Those of you who are TPAs or other players, you have to offer solutions to your clients. You cannot bury your head in the sand and pretend this is coming because this is expensive. This is very expensive. Wegovy is $1,330 a month. Our Zepbound is currently priced at $1,060 per month. It's a lot of money. 20 people is $250,000. These are not specialty meds, so we can't carve them out of the health plan. We can't do alternative funding. Frankly, I think Canada is going to shut the gate on this one and not let these drugs be imported. Disease versus lifestyle. Don't raise your hand. I don't want to embarrass any. How many of you today would say obesity is a lifestyle? How many of you would say it's a disease? The American Medical Association, the American Diabetes Association, every medical group out there classifies obesity as a disease. There's one holdout who calls it a lifestyle, and this is a huge important thing. It's the federal government. they classify obesity as a lifestyle because, yeah. Federal, darn, they are always listening. Don't kid yourself. I used to be a board certified psychiatric pharmacist. I talked to a lot of patients who explain government interventions to me. So, the federal government classifies obesity as a lifestyle because as soon as they call it a disease, Medicare Part D has to cover it to the tune of $50 to $75 billion a year. We can't even estimate what the cost is going to be on that. The federal government will reclassify obesity as a disease within the next 12 to 18 months. I was at NABIP, CapCon. This is insurance agents go up to the Capitol Hill. They talk to people. They have folks come in, and I followed a gentleman out. He is the health advisor to the House Ways and Means Committee. And I followed him out because I didn't want to ask this and put him in a bad spot. And I said, when are you reclassifying obesity as a disease? And he turned kind of ghost white. He goes, how do you know we're talking about that? Government people. Everybody's talking about it. What do you mean? How do I know? There's no secret you have. When the federal government reclassifies obesity as a disease, commercial insurance will follow. It does every time. So if you're an employer and you're like, I'm never covering these because they're expensive, you probably will not have a choice. And let me tell you, pharma is really smart. Wegovy is now indicated for obesity with cardiovascular risk factors. So as a PBM, we cannot, even if you as an employer don't cover obesity medications, we cannot deny on a PA Wegovy for someone with cardiovascular risk factors. It's an FDA indication. It's a great way to get an employer sued. Oh yeah, employers are getting sued left and right on this stuff too. That's going to have a huge influence. So clinical guidelines, right? Again, I told you the AMA, the ADA. The ADA says for the treatment, the number one treatment of diabetes is weight reduction for type 2 diabetics. Type 1 diabetes, completely different disease state. They shouldn't even have the same name. It causes a lot of confusion. For type 2 diabetics, the first line treatment is diet and exercise and weight loss. When that fails, second line treatment, according to the ADA now, are GLP-1s. Think some lawyer is going to get a hold of that and start suing? The ADA says you should cover this. Why aren't you, Mr. Employer? You're going to cover these medications whether you want to or not. Get a plan. Be prepared. Forever and ever and amen. For those of you who are Catholic, you will recognize that. For those of you who are Randy Travis fans, you will recognize that. I do not think these are forever medications for weight loss. And if you invest in the health of your employees, if you take control of your own health plan and you teach people how to eat right, exercise, you give them tools to be better, they will not need the medication forever. They should get better. Let me be honest. If you're on a GLP-1 and you lose weight, once you stop, you will get a little bounce back. Probably because most people go a little too far anyways. That's just the nature of losing weight. The question is, you go 20, 30, 40 pounds. That's a problem and something we have to look at in the PA. Do people get a second bite of the cherry in your thinking? The other thing about GLP-1s that I think is really important, I mentioned what wonderful medications they are. Other than insulin, they are the best treatment for diabetes, type 2 diabetes we have. They're not used for type 1. It's a pretty amazing thing. We're seeing them studies fatty liver disease. I already talked about PCOS and Ozempic babies. It's a study that men who have been diagnosed as infertile are suddenly fertile and, you know, having children. Fatty liver disease with MASH. There is a host of disease states coming. Anybody ever heard of type 3 diabetes? This is a new phrase we're using all the time and behind the scenes in healthcare. You can't answer because you knew the Gila monster question. That was a good one. Do you have any idea what type 3 diabetes is? Microvascular dementia brought on by diabetes. So we think that particular dementia is really more of a diabetes problem than it is a brain disorder problem. GLP-1s will be studied for that. They are being studied for that. Be amazing, because let me be honest with you, this is what I used to do in clinical practice. Once you have dementia, we can't fix that. Contrary to all these drugs coming out there, we will never fix dementia. Once you have it, you have it. So take control of your health plans. Get health strategists, get good advisors, get good TPAs, get good everything to work with you. You're gonna hear a little bit from Spire, hear about some things you can do that I think are really important. It's a good setup for them. Invest in the health of your employees. And did I say it wrong? Okay, but it's a good setup. But know that this is coming, and make sure you're helping your employees with this. Medications are tools and nothing more. Questions? I, unfortunately, as soon as we're done, have to leave. I have to be in French Lick. We're taking our vice presidents for strategic planning this week, and I have to talk at 1:30. I'll probably be late. But if you guys have GLP-1 questions, Aaron back there can answer them till the cows come home. It is the 1 through 25 questions we get right now that everybody has. So thank you so much, and we appreciate the opportunity to be here.
Thanks, everybody. We're going to take a 5-minute break, so feel free to stretch, go to the restroom, check up on emails, calls, text messages. I'm going to do a little talking. Don't worry. Feel free to, don't feel uncomfortable. Just give you a heads up. On August 6th, we're going to be having an event here. It's going to be area business leaders, healthcare experts, and public officials. We're going to be recognizing Indiana's top health plans. And I know a lot of people in the room have worked really hard to make their health plans the most competitive it can be. So if you would like to submit your health plan to receive a Rosie Award, you can actually do it yourself. There's a QR code over here, and we also have information on each table. But you can submit your own health plan for nomination by June 28th. And here's the steps on submitting the nomination with the QR code. So again, if you got questions, here's contact information. You can contact us as well. Nominations must be received by June 28th.
All right. So I'm going to introduce Kelly Fenol with Spire Wellness. Kelly Fenol is a seasoned professional in wellness strategy dedicated to empowering individuals and organizations to optimize their well-being and performance. With a unique blend of experience, expertise, and passion, Kelly has become a trusted advisor in the realm of health and wellness. Kelly brings over 20 years of experience in industries such as healthcare, corporate wellness, health coaching, and lifestyle medicine. Throughout her career, Kelly has held key roles in developing and implementing wellness initiatives for a diverse range of clients, from Fortune 500 companies to small businesses and community organizations. Brian Schroeder is the founder and CEO of Preventia, a health tech platform that focuses on management of habit, behavior, and mental health. Preventia was born after he spent 20+ years in big healthcare, watching patients struggle to manage their chronic health conditions. Brian serves on the advisory board of both the Wellness Council of Indiana and Jump In for Healthy Kids. Brian received his master's degree in public health from Indiana University and is a Lean Six Sigma Black Belt with expertise in building business strategies around preventive care, population health, mental health, and behavioral health and nutrition. Brian and Kelly, take it away.
Hey, everybody. You look good from up here.
Check, check. Okay, so get started?
Yeah.
Good. So my name is Brian Schroeder. Got a pretty comprehensive bio there, but before I introduce myself any further, I think I could say with complete confidence right now, I can tell you the #1 thing that you can do to save on your healthcare costs, and that is to not get in a scooter accident 2 days before you come up and speak at a NextGen benefits conference. So if you see me limping a little bit, That's why. No shame. Don't do that. But as mentioned, I've been in healthcare for about 25 years, actually, and I spent time working in pediatric cardiology at Riley Hospital. I ran labor and delivery units for underserved population hospitals, Eskenazi Health here in Indianapolis, if you're familiar. Well, my job was always really to be in sick care. I was a sick care hospital administrator running multiple practices. And then in 2013, my wife, Amy, was diagnosed with heart failure. And that was after she gave birth to my daughter. So that was about 10 years ago. My daughter's about to turn 11, actually. So it's about 11 years ago. But it was a big wake-up call for me. So I changed the trajectory of the type of care that I wanted to be in. So I made the switch. And I decided I was going to get into preventive care. I was going to work for underserved populations, recognizing the fact that I saw how difficult it was for my wife to receive the diagnosis. And we've talked a lot today about misdiagnoses and, pretty critical diagnoses. I saw the difficulty that she had in being able to manage her condition. We didn't have GLP-1s, we didn't need them. What we needed is to focus on eating healthier, moving more, and stressing less. So while the doctor was diagnosing my wife with this issue, it's really, you reach a critical point where you realize that you have to execute on the plan now, and you may not know where to begin. And we call that the self-efficacy. It took many years for her to make this adjustment. She comes from a Puerto Rican family. She also comes from, she lives, her other side of her family grew up in Corydon, Indiana, very unhealthy lifestyle. She was very used to a certain thing. And it was a big wake-up call for her, for me, for my family, for my wife. So I made this change. I got into preventive care and did so when a mentor of mine told me that you really shouldn't do that. You shouldn't especially go to an underserved population and work with them because those people are so sick. How are you ever supposed to make a difference? And that's exactly why I fired that mentor and did it anyway. I wanted to make a difference. I saw the struggle. I usually forget to say, by the way, my wife is doing better, much better actually this past year, really mostly by focusing on management of habit and behavior. She was told by her cardiologist that she no longer even has heart failure. So going from her heart pumping at an ejection fraction of 12 to 15% back to normal. So very blessed to have her here and to be here in the first place. So that's a little bit about my why and why I did this, and I probably need to click through this. So Preventia, well, I mentioned the work that I had done with underserved populations and running these, these different clinics, but I switched to being an entrepreneur, and I really started focusing on preventing people from going down the path of even being diagnosed in the first place. And how do we do that? Or if you are diagnosed, is there a better way to do it? We just heard the last speaker talk about you can make a difference by focusing on management of your habit, your behavior, and your mental well-being. But what I also learned doing this work for a long time is health does not happen in doctors' offices. Health happens at home. It happens in real life. It's our habits and our decisions that we make every day that drive our overall health outcomes. 80% of diabetes is actually preventable and in some cases reversible just by modifying your lifestyle, your habits, your behaviors. So that's kind of what we focus on prevention. But in order to do this, as I said, my wife had to execute on the plan. And in order to execute on that plan, you have to know where to begin. And behavioral science tells us that you need at least 6 hours of touch points with a real person to actually elicit any sort of real behavior change. And that's not scalable. So in healthcare, while we have lots of doctors that are doing lots of diagnosing and lots of treating, when it comes time to execute on the plan, it means multiple touch points. And as a coach, you know this, Kelly, right? It takes multiple touch points with a coach or a dietitian or sometimes a mental health provider in order for you to actually be able to make that change. So in the meantime, we've got 92% of employees, those that we work with, believe that it is important to focus on these things. Most of our employees are struggling with their sleep. They're struggling anymore, especially after the pandemic, with mental health issues. They're struggling to balance their work in their life, and to keep that level of balance is incredibly important. And in the meantime, 77% of employees have experienced some sort of stress in the last month. So what does Preventia do? Well, I was running these lifestyle medicine clinics in healthcare. That was towards the end of what I did. Once I got into prevention, we started running lifestyle medicine clinics. And really what those clinics were about were not treating patients with a pill. It was about treating them with lifestyle-based interventions. If you showed up to our clinic, we were going to treat you with nutrition. We were going to treat you with a better way to manage your habit behavior, your stress, and we were going to talk to you about physical activity. Again, lots of touch points. Plenty of doctors, not near enough health coaches, not near enough dietitians to do this work. Also, a lot of those services aren't really reimbursable. So when we're driving revenue, and I don't know who said it earlier, but when you talk about premiums, it's revenue for the health insurance companies. When you're going back to the doctor's office, it's revenue. If it's not generating revenue, you may not have the staff to support that revenue. So Preventia, at the end of the day, I would think of what we're doing as a network of care providers in multiple therapeutic areas that can be configured to work with populations and focus very specifically on maybe one or two different therapeutic areas for that population. So health coaches, clinical dietitians, we now have mental health coaches, therapists. We're all going to slide along our own personal journey, along a continuum of care. And that might be low acuity. I was just diagnosed with prediabetes, and perhaps I'm suffering from isolation and loneliness, all the way to I'm cardiometabolic, co-prevalent with anxiety and depression. Along that, as we slide along that continuum, our severity is either lower or higher, and we need to be able to meet people where they are in their individual journey. So many people are solving the problem in a number of different ways. These are just a couple of different examples. We've heard about GLP-1s. I probably don't need to say anything else about it. They do some amazing things. They are not the answer. The only way that they can be the answer is with some sort of sustainable behavior change. In order to achieve that, we need to learn how to be able to better manage that behavior change. And sometimes that means creating a relationship with, God knows it, another human. It doesn't have to be AI. It doesn't have to be a technology. There's some great technologies out there. I'm not dissing technology. I'm a tech founder. But people and relationships is what establishes trust and rapport is what leads to results. How do we do that? GLP-1s alone, you can't do it. Employee assistance programs, there's some amazing ones out there. They're getting more and more innovative all the time. We're reacting to the problem, though, with an EAP a lot of the time. Those that don't have a coaching model, we see therapists, 1-800, dial a therapist, you get a different person every time. Usually we're in crisis or we already have a problem. We need to be more proactive. And then there's a lot of really cool mental health apps out there that are more supportive mechanisms for behavior change. You can do meditation exercises. There's great content and education and videos. But that's how most are actually solving the problem. What we're doing is trying to find another way. Leverage those amazing individuals that are out there, not just in the United States, but globally, that are trying to build a business around health coaching. They're trying to find a way to break into healthcare, to break into the employer, but they can't necessarily do so. It's hard to find quality care providers that are focused on management of habit and behavior. And we can't just pick one thing out. Like with my wife, I couldn't just say, you need to see a nutritionist. She needed more than that. She needed to focus on her mental health. She needed to focus on her physical health. This is very difficult to do. So how do you build a network of providers that are out there that are non-clinical, they're not doctors, and do a better job to help connect someone to the care they need when and where they need it? At the end of the day, that's what this is about. It's about a whole person approach to management of habit and behavior. We call it the coach approach. No surprise, right? Most of the providers on our platform are coaches. These are not people that work for Preventia. I'd have way too much overhead. I would have been out of business in my first week. Same reason, again, healthcare doesn't hire these types of providers. This is like any other healthcare network that has been built in the United States. They work all over the US, and they are really board certified, trained to differentiate and triage for more complex care when it's necessary. But at the end of the day, they just do what they do. They tap into intrinsic motivators, and they work with patients on advancing them and helping them get to the next stage, or keep you from going down a path to illness. It's a little clicker snap. See, here we go. And again, this is just about getting people to the right care at the right time. I don't need to beat this piece to death. Now, if I didn't have a torn calf, I would probably get up and walk around and talk a little bit about this more. But this is the care continuum. This is the way that we look at it. Again, we're all going to slide along this continuum. I see a lot of health coaching programs where you have an on-site health coach, and I love on-site health coaching programs. But when you've got a population of 5,000 people, are you truly and confidently going to be able to say that you as a coach can meet someone where you are? Do you have the specific training and discipline to work with someone who is cardiometabolic, co-prevalent with anxiety and depression? You may have some cool pieces of training, but there's not going to be enough of you anyway. So how are you going to touch everybody? So on this continuum, we go all the way from that basic health coach where somebody might just really want to lose a little bit of weight. They might just want to get a little bit healthier, all the way to psych. Because again, mental health is a huge component to this entire thing. Again, we were talking about EAPs earlier. The EAPs focus on mental health only, but if they say, well, you are depressed because you were recently diagnosed with diabetes and you're struggling to deal with that, that's a referral out to a primary care provider or perhaps to a health coach on another network. But with an integrated model like this, it might be simply getting you to someone that's in network, or if you're a mental health coach and you're working with someone on this same problem, just so happens you're already trained in managing the whole person anyway. So you can focus on nutrition, you can focus on weight loss, and you don't have to change providers. So it's a really cool, just kind of integrated model. So I mentioned earlier that I'm a tech founder as well. If anyone had told me that I was going to be a tech founder about 5 to 7 years ago, I would have thought you were nuts. I knew nothing about technology other than I had tried a lot of different tech products when I was running a wellness program in Eskenazi, and none of them ever worked. They only worked when they were paired together with real people. But this is what we've built. We have a very comprehensive and robust technology that, again, is mostly focused on driving people to the right provider at the right time and making sure that they can execute on the plan. But what comes along with that? Well, content, education, typical wellness stuff. Everybody in here has probably heard Virgin Pulse. It's a very Virgin Pulse style platform on the wellness side, but our focus is really more on that connection to a human. There's a social determinants of health component to this that we don't actually have highlighted here, but that actually helps you tap into community-based resources that are in your own area. If you have employees that are in different rural communities, you can tap into that and find out where are the food pantries, where are the financial assistance programs, perhaps housing. All of this is about, again, recognizing that it's not just about that meditation video, that article that you read on nutrition, or 1-800-DIAL-A-COACH, the one person you talk to, an expert. There are other things going on with your employees that you may not recognize in their own communities that also need to be addressed. So we think of this in a very, very holistic sort of way. This is just an example. There's a really cool employer here in Indianapolis called MW Cold. And we did a study with them. I loved them because they hire 75% of their workforce are going through prison reform. So when we think about engagement and whether or not people will actually use services like this, when it's designed right and people have an opportunity to connect with an actual human, we saw engagement through the roof. 90% of those employees completed all of their visits every single year. They had flat healthcare trends. Their engagement was absolutely amazing. And in the meantime, they rated their experience as 4.8 out of 5 stars. So people love working with coaches. They love models like this where they have easier access to providers and they're not just working with the doctor. So at the end of the day, I know we're going to be talking about this a little bit more on a panel. That's what we do at Preventia. It's not about Preventia. It's about every talk before this today. It's about recognizing the fact that if you don't take this seriously, healthcare can kill you. If you don't execute on the plan once you've been diagnosed and you just have hope that everything's going to be okay, that's not going to be enough. If you get on a GLP-1 and you take that, is that really sustainable unless you're pairing it together with an actual plan? You got to execute on the plan. And I always say, and just to kind of close this up, before we can be well below the neck, we need to focus on being well above the neck. Mental health is a huge, huge piece of this entire thing. So I'm going to pass it on to Kelly and let you take it from here. And again, I know we're going to get into this a little bit more in the panel, but thank you for having me today and thanks for the time.
Excellent. Well, Brian and I are up here together. We have similar backgrounds as well. So I also started more on the medical side of the continuum and really didn't feel at home there, I'll say, and really fell in love with the preventive side as well. So again, digging in with people and also with population. So at the beginning of my career in health and wellness, it was definitely more on the one-on-one, you know, doing the health screenings, doing a lot of coaching, but then certainly got into more of that leadership and strategy piece. And that's where Spire is today, is more of that strategy partner that is helping to bring this together. So I don't know about you, but sometimes I go to these things and I'm sitting there like, wow, this is a lot of information. There's a lot of good things going on. How do I put it into action? How do I make decisions on this? What does this look like? What would this look like for my population? And so that's where Spire can come in and help with that and really operationalize it. So when we're sitting here, there's a lot of considerations for, you know, employee health for our population. I know for me sitting in different spots and for the clients that I work with, these are the type of questions that they have. Which programs are best for our population, right? So what makes the most sense? How are we putting it out there? Who should be getting it? You know, who do we make it available to if we only have limited dollars? How do we, you know, distribute that so that people are, you know, getting the best care, but it makes sense and it's cohesive. The second one, how do we have the bandwidth to do this? So again, a lot of people that I'm talking with, they have full-time jobs. They have other things that they're doing. Most of you here are, you know, sitting here in the business of something else, right? Other than healthcare, other than health and well-being. And so, you know, how do we find the bandwidth to make this happen? Because it can really seem overwhelming. How do we get employees to take advantage of these? So again, we can have great programs in place, but if our population and our team isn't taking advantage of it, isn't getting involved, isn't understanding it at the base level, it might not go over very well. We might not get the results that we want, right? Because they're just not participating in it. How do we know if it's a good investment? So again, you know, when you're sitting there trying to make the decisions, you know, your advisor is there, you know, again, Spire can come in and help with that information of all the power behind the different groups that we've worked with, programs that have gone really well, programs that have not gone very well, and bring that together. So, and then at the end of the day, again, benchmarking to, you know, what were your goals with this? What does the reporting look like? What do those outlooks or outcomes look like there? And then will these solutions be sustainable and fit in with our culture? Again, that's a big piece of it when you're looking at which of these do I put in, which ones make the most sense, what do we need, what also do our employees want for those things. So with Spire's approach, and again, I've been in the industry a couple of decades as well, again, a lot of trial and error with, you know, learning some of these things and just constantly going after what's working, what's out there, how do we put these, you know, together in a way that, you know, makes sense for each and every group. Even if they're the same type of solutions, we might be, rolling them out in a different way. We might have a different strategy on bringing that, to fruition so we can meet the goals of the organization. So always going to be promoting those things that are evidence-based strategies. Again, there's a lot of stuff out there that, I don't know, very light, I guess, wellness light, where, okay, I think when we started a couple decades on wellness, a couple decades ago in wellness, all right, maybe it was a treadmill, maybe it was fruit Fridays, maybe it was,
Lunch and learns.
yeah, lunch and learns, hydration. And not that those are bad things, but is it going to drive your group to where you want to get? Are we really going to see the health outcomes, that we want to see? So really digging into, what is the evidence showing us on what are those hard-hitting programs that are going to help that population? Again, being innovative. So maybe we're doing some of those things, but we're going to do it in a way that makes more sense for our culture. We're going to look for, again, how can tech support us in this? How can we think about something a little bit differently? How can we break this apart and put it back together so that it's a little bit more productive for us specifically? Employee engagement. So again, if we're not getting the participation, if we are not engaging our population, it's not going to work, right? So it can be a really great program if no one's using it because they don't know about it or they don't believe in it or they're super suspicious or they think Big Brother's watching them with some of this stuff. So we really have to be careful on how we're messaging that and getting it out. And then the data-driven results. So again, what are our benchmarks? How are we measuring this? How are we, maybe even reconstructing our goals, and we find something's not working. So what do we need to do differently? So we're really looking at the data over and over again to make sure that we're driving it the way that we want to. With Spire, we kind of look at it again on that continuum. So we talk about continuums a lot. Brian talked about, the continuum of care with that. For Spire, we know that there are people that are actively involved in medical care, and those are people that are not on those charts. They're kind of, up at the top there. We've got people that are, fairly healthy, and we're really just, trying to keep them there. Those are at the bottom. And then we've got this continuum of people in between. We really feel that condition management piece where they've got a chronic problem, and it's medically, maybe doing okay, but they need some help with those lifestyle pieces, with the coaching piece, to keep them there and to really empower them to do a little bit better. High risk and emerging risk, again, we feel like that's really important. And those are really where Spire operates the most to bring solutions in that are going to help those people, hopefully prevent them into getting, into the too high cost, medical pieces there, but also, not only doing the culture pieces. We have solutions for that as well, but really want to push into those heavy hitting pieces where we get them, get the results. All right, so what does a recommended strategy look like? Again, really an innovative or integrative approach on this. And at the core of it, we're really looking for those outcomes. So again, a lot of these are things that maybe you've done, maybe you're doing right now, great, but how can we build on that? How can we make sure that we're really driving to get the results that we're looking for? So knowing your population is going to be really important. So getting in on that risk assessment, doing the preventive screenings, or making sure that people are getting their baseline care with their primary, primary physician on that and getting that baseline so we can look at what's happening. A lot of times in medical, their doctors aren't going to do anything until they get, unhealthy, right? So we're looking more for that emerging risk, for that person that maybe they're okay today, kind of like Eric was saying, like they don't feel great, but like on paper they look okay. How do we get to them first so that we can keep them there or empower them, to drive their risk even lower on that as well. So that screening or that physical is really important, along with a health risk assessment to make sure that we're getting those baseline pieces there. And then again, the personalized resources, again, are important, right? Everybody needs something different, depending on age or, what's going on with them or, what's happening even in their family life, right? Maybe they've have people at home that are not on board, how can we get them those personalized resources that make sense for them and meet them where they are, kind of like Brian was saying. we firmly believe in that coaching piece. So all of us need a coach, right? Think of your, even your sports teams. It's like, okay, they wouldn't be a great sports team, right, without having a coach, even though they're, the top of their field, right? They need a coach. A lot of us need that coach. We really believe in that because that one-on-one relationship helps drive a lot of this. So that's a big piece of it. And then rewards, do we need to incentivize this group? Maybe we don't. Some of the cultures we don't. Some of them, if we're really trying to get them started, need a little bit of a boost. And so what does that look like? What is a meaningful reward for your population? And how do we drive into that? Again, with this, there's lots of different things that we can put into play. So we're at Spire really excited to be partnered with Preventia. So that's why we're sitting up here together. Preventia is our #1 platform that we use with our clients. So for that, wellness piece and the pieces like the personalized resources and the coaching as well. So really like that. Maybe we have other pieces that we put in there. And then, like I said, when we're looking at that chronic condition management and some of those, do we need to think outside the box, or maybe with the medical plan that they have there, do we need to add some other pieces in there as well? So putting those together. One program that we have as well is called Physio. So with this is a lifestyle medicine program. They have been around for a really long time, very, very well studied, covers all the pillars of lifestyle medicine and seeing a lot of hard-hitting results with this. So again, very evidence-based, very well studied. And now, when Eric talked about you need to have a lifestyle component of your GLP-1 strategy, this is, a piece of that. There are other coaching models out there that can help with this as well. But these are the types of things that when we're putting together the strategy and looking at what's going to work for our group, what are the pieces that we need and who needs them, right? So is this just for diabetics? Is this going to be for weight loss as well? Looking at all those pieces, looking at all those metrics. So again, just one example of some of the programs that we can put in place as well. So at the end of the day, the take home here is that we really want to work and be a partner with our clients. So first of all, the client, but also with the advisor and the medical plan as well. A lot of times these things are sitting kind of siloed out. So how do we get the strategy to really work together? How do we look at, what's happening with the claims, but also what's happening with, the information that we're pulling in from the biometric screenings and the risk strategy to make it make sense, look at those data analytics, really be results driven with it, because that's where we're going, again, to see those dollars saved and where we're going to really see the outcomes that we want with our participants. How do we drive the people that need coaching into the coaching model? How do we get that? Spire is really happy to be a turnkey solution. So again, we can do a lot of this heavy lifting. We come in and partner with you to make sure that it makes sense for your group, that again, we're giving you that bandwidth so that you don't have to do a lot of that heavy lifting to get these things lifted off. And then again, really putting the pieces into place that are going to support the NextGen benefits, all these strategies that you see here, along with Health Rosetta and other medical strategies that you might have out there. All right, so that's a little bit. I know we'll have some more questions with the panel as well, but again, how do we put it into place? How do we really put that strategy together that hits hard for those chronic conditions, the high risk population and those emerging risk populations? And so we'd love to be your partner on that.
Thank you. Any questions? Cool.
Thank you.
Thanks a lot. I can get down here.
Thanks, Brian and Kelly. Our next speaker is Dr. Chad. Dr. Chad is the founder and CEO of NRG Physiotherapy, NRG Health, and NRG 360. NRGPhysio is a cash-based physiotherapy clinic serving active adults, athletes, and fitness enthusiasts who've already tried and failed other conservative management, but still have pain and limitations. NRG Health provides on-site health screening and primary care to organizations looking to improve healthcare spending and employee wellness. And then NRG 360 is the proprietary delivery of physiotherapy-inspired physical wellness at scale, delivering musculoskeletal evaluations, diagnostics, and video-based self-care, all via text. Message stream through the purpose of reducing, preventing, and resolving root cause issues associated with pain. Dr. Chad loves educating both coaches, athletes, and individuals looking to improve their physical health and how to optimize movement and mobility, increase performance, and overall health, wellness, and fitness. Dr. Chad earned his doctorate in physiotherapy from Harding University in 2014. Has continued to grow in knowledge and skills as a clinician, business owner, and athlete. Likes lifting, basketball player, and golfer. And even though those are important passions, he's first a husband to Jenna, father to his 3 kids, second, and an athlete in a distant third. Aside from that, biking, playing guitar, and all things business are certainly interests. Dr. Chad, please join us on the stage.
All right, I'm on, I can hear it. That's a really nice intro that I wrote on my website like 7 years ago. And as he was reading it, I remembered Diana asking me for a bio. So that one will just have to do. Some things have changed in the last 7 years for sure. All those things are still true. We've expanded a little bit. We're doing some things a little different, but appreciate Ben asking me to speak here today. He said, hey, do you want to do this? I said, sure. And he said, can you do it in 20 minutes? I thought, no way. So I said, sure. So I've got 19 minutes to change the way you guys think about musculoskeletal health, which will be referred to as MSK from here on out. Everybody good with that? All right. So we're going to start with a little game. You know the wedding game where they ask how long you've been married? You stay on the dance floor. So we're not going to dance. Everybody raise your hand if you have pain. If you're comfortable raising your hand, or if it hurts to raise that arm, raise the other one. Okay, so some people have pain and didn't raise their hand. We're going to acknowledge that. That was probably 70% of the room that is dealing with some type of pain right now. Raise your hand if you've had pain for 6 months or more. Okay, and he's even got a fresh one, 2 days ago. A year or longer. Okay, still some hands. 10 years or more, let's just go big. Okay, we got some, all right. So there's some misconceptions, I think, about musculoskeletal health that shape the way that people deal with pain for very long periods of time. And when we think about how consumers engage with pain relief, especially as it relates to healthcare, there are just some real slippery slopes you can get on that are going to lead to higher cost things, whether you're a consumer and just going and accessing things on your own, but really if that's you, you're somebody's employee probably, right? So when we're thinking about how does this fit into the overall context of employer-based health, we have to be thinking, how do people think? People who have pain for long periods of time, they've been on YouTube a lot, okay? Like people know about sciatica and plantar fasciitis and all the different solutions that are out there. Musculoskeletal health is, MSK, sorry, we'll keep it short. MSK is one of the only things that people can really attempt to sort out on their own. You can't go to YouTube and really diagnose cancer or diabetes. You can see the symptoms and you can hypochondriac yourself into anything based on what you read, but at the end of the day, there's no solution for those unless you work with a professional. Musculoskeletal health, people can try all kinds of things. They get very comfortable thinking they know what is going on and trying a lot of things that ultimately end up not working. Everybody who raised your hand the first time, who has pain, raise it. Only put your hand down if you have not received care for that pain somehow. Everybody's been somewhere, okay? We've been to the doc, we've had some meds, maybe the chiropractor, been to the therapist. Okay, so we're trying a lot of things, but we're still sitting here with pain, and that's a problem. Who has tried something for pain and gotten relief temporarily? A lot of the same hands, okay? If you can get relief temporarily, you can get it permanently. You're just not doing the right things yet. So, appreciate you playing that game with me. Now that we know this room looks like every room I've ever been in, every gym I've ever been in, we're all in good company here. Let's find a slide. I'm clicking the next arrow. No worry. All right, let's try this again here. That's me. Okay. Does this look familiar to anybody? Primary care, get some meds. Back to primary care when they didn't work. 4 weeks. Hey, come back in 4 weeks. And if it doesn't work, probably getting a referral to specialty. Okay. Probably going to get meloxicam this time instead of the lesser version that you got the first time. And then here's a couple different directions this can go. PT, which is not going to be focused on the root cause. We'll discuss some of that maybe in the panel. It can't be, or you won't get paid. MRI, a high-cost non-solution that identifies a potential source but not the cause of the pain, and we'll talk about that a little more extensively here in a minute. Potentially going for injections. Okay, so these are all higher cost things. Like once you move past going to the doc, PT is expensive, MRIs are expensive, injections are expensive, everything gets more expensive. Every step somebody takes without pain resolution is a step towards a higher cost procedure. And so obviously those stepping stones all lead to surgery. That is the final piece. If somebody doesn't get pain relief, but they've accessed PT, chiro, meds, injections, maybe a couple of other more conventional types of solutions, and they still have pain, they've stacked up a lot of evidence for why surgery will be necessary. And so when we talk about misdiagnosis and getting to spine surgery and it's not needed, the research is thick, really for the spine, but for a lot of musculoskeletal cases. And it's because of the way people start that ultimately gets them where they finish. The plane that flies 1 degree off for 3,000 miles, you've heard this analogy before, yes, ends up way far off from its intent just because of that, where it started and that slight misdirection right out of the beginning. All right, but all things lead back to primary care. Nothing wrong with that, but we just need to be really intentional about how we're helping people get there. Surgery obviously may solve pain. We see it solve pain very frequently because it puts people on a period of total rest, 6 to 8 weeks. They resume normal life, the pain comes back. But during that time, we had time off, lost wages, decreased productivity. It is the highest cost profile for sure. No guarantee. That's a big one. Anybody working with anybody in the healthcare space that gives a guarantee on results? Tough to do, isn't it? But still, we've gotten comfortable receiving whatever based on diagnosis given. Nelson mentioned people just take a diagnosis and run with it. That's physical therapy. If they receive a piece of paper that says disc herniation, that patient is going to get clamshells, leg raises, sit to stands, and a whole lot of press-ups. Okay, that's just the way it is. And there's so many reasons for that we can't get into, but we just got to start thinking differently about how are we going to approach musculoskeletal health if we're going to make not only large impacts in people's lives, because that's really where the effect is. We get to have hundreds of conversations a month with people who have already failed physical therapy. We're having about 200 conversations right now. That's about to go to 400 or 450. Every single conversation we have, tried and failed physical therapy, chiropractics, meds, and injections. It's a really large problem. But like we said, as a general rule, the longer somebody goes with a symptom, the closer they're getting to something that's going to cost a little more money. All right, so we're going to talk about a couple of things that get floated around a lot. Pain is a medical problem and movement is medicine. Who agrees? Movement is medicine. All right. See what you guys think about that in a minute. If those things are true, there are some other things that have to be true. And if movement is medicine, then people with gym memberships, bikes, and long walks on the beach, pain-free. Who likes a long walk on the beach? It's so hard to walk in the sand. I don't get you people. Okay, people using therapists, Pelotons, and Pilates, they would have to be pain-free because movement is medicine, right? And if it's a medical problem, medicines, injections, and surgeries have to solve the problem 100%. Because if they don't, then that can't be the answer to what we're looking at. So, pain is not a medical problem. Pain is a movement problem. And if movement is the problem, it cannot be the medicine. There has to be something deeper than that. You have to zoom out. You have to look at a broader scope. Just like when we're looking at diabetes, obesity, chronic health conditions, chronic preventable health conditions, a big topic that's going around here today. When is the best time to solve that problem? Bunch of whispers, bunch of little mice. Okay, when's the best time to plant a tree? 20 years ago. Okay, so if we're looking somebody in the face today who has this symptom, the solution was 20 years ago. Okay, when we're looking at musculoskeletal health and pain, especially pain that has been unsolvable and chronic in nature, this problem started years ago. And it's so easy to take a snapshot of somebody now and understand what are the things they've been doing for the last decade, 2 decades, that have led to the state that they're in today. Because movement is highly predictive for pain. But where we get stuck in medicine is source versus root cause. Would we all agree? This is the same conversation with all facets of healthcare. We're stuck on source of pain, we're stuck on symptom, and it's more difficult to get to root cause, right? So this is how we define these things. Source is a potential anatomical structure that may be generating pain signals. As I say maybe because we have a ton of data on, especially the spine, that shows millions of Americans have herniations, no pain. So we can't be confident that just because we see that on an image that it is the source of the pain. So treating the image, which is very common, it's often what leads to advanced procedures later down the road because you can't treat an image, you have to treat the person. And this goes for everything. Meniscus tears in the knee, rotator cuff tears, trigger points. Anybody know what trigger points are? Nasty little things, okay? Easy to get rid of, still not the real problem, just a symptom of the bigger problem, okay? Root cause is what creates those things in the first place, right? So this is going back 10 years. This is taking a look, zooming out. What's going on in the entire body that is creating this local thing that this person is displaying at this current point in time? And the way we do that is through looking at movement. Has anybody heard that therapists are movement professionals? Well, that's good, because they're not. They label us as that in school, but the truth is most therapists don't know jack about how to squat, and they don't know squat about getting jacked, okay? I just came up with that. It's pretty good. But if we're going to send somebody with movement being the medicine, shouldn't this person really be an expert on how do you move? But instead, we get things that strengthen muscles because you're weak here and that's why you have pain. Very common. You have pain in your back because your glute minimus is weak. That's never going to be true. Okay, we've seen this a trillion times in the last 10 years. Weakness is a fitness problem. It's not a medical problem. And if weakness is the problem, then fitness is the answer. But we see so many people at the gym, big, strong guys and girls, extreme feats of athleticism, but they still have pain. They're plenty strong. We get people in the clinic all the time. They're like, oh, yeah, I saw this guy, and they said, my glutes are weak. Okay, well, how much do you squat? 450. Okay, your glutes aren't weak. This is good news and it's bad news, okay? But the truth is, I really appreciate Nelson talking about this because it's impossible to correctly treat an incorrect diagnosis. Can't do it. And it's impossible to completely treat an incomplete diagnosis. And when we're looking at the musculoskeletal health space, both of these things are happening, okay? People are getting diagnosed with a source of pain and not the root cause. And they're also getting a very minimized version of what might be correct. They don't have the whole answer, okay? A disc bulge is one piece of a 100-piece puzzle. And we have to solve for all the variables if we're going to get people pain-free in a sustainable way. Just like GLP-1s combined with lifestyle coaching. Okay, GLP-1s are great, but if people don't change the way they move and change the way they eat, the GLP-1 ultimately will be ineffective in the end. Somebody comes off, they have the same bad habits, back up the ramp they go on the weight scale. And so, like, there's so much alignment across the facets of healthcare and the conversations in this room. You know, I'm happy to be a part of this little facet of musculoskeletal health because we're real passionate about this. But if we're going to get to the real diagnosis, we've got to start looking at movement in a more comprehensive way. You know, if you guys want to, we can file you through single file. I can watch you squat and tell you every pain you have or will have in the future. Anybody want to play that game? No hands raised, though. So how do we do it? We created a couple things in the last 3 or 4 years based on, one, we went cash. So we don't have to do what insurance tells us to do. We get to do what we want to do. Mostly that means we get to do what makes our patients better regardless of what anybody says about it. That means we don't have to fall victim to reimbursement-based medicine, which some of you might know as evidence-based medicine. And we can just tinker around with our clients until we find that magic thing that works. And what happened is I started checking every joint. Somebody comes in with shoulder pain, I'm checking ankles, knees, hips, pelvis, spine, shoulders, wrists, hands, and neck every time. What we noticed after probably 10 or 12 patients was everybody's got the same problems. Nobody was a special snowflake. Okay, the person with shoulder pain has stiff asymmetric ankles. The person with back pain, stiff asymmetric ankles, stiff asymmetric hips, stiff asymmetric shoulders. There is probably not a normal person in this room in terms of, does your body have the prerequisites of mobility to live your life pain-free? It's the American way. All right? But what we noticed that was super interesting was if we check all the joints, just kind of jot down what are we seeing. Is the mobility normal, yes or no? Is it symmetric, yes or no? And to what degree? The common thread through everything was that each person had an asymmetry in their pelvis, which, you know, the PT community is divided. Does the pelvis move? Yes. Does the pelvis move? No. If it moves, how much? We're not going to get lost in that. What we will get lost in is the fact that when we adjust the pelvis first, or at least that's what we think we're doing, all the joints change immediately. So the ankle stiffness disappears. The hip asymmetry goes back to normal. Still might be stiff, but it's better. The shoulder, this was the crazy one, a shoulder that's missing, you know, 30 degrees of flexion, normal after just the pelvis. And this is why it's so important to zoom out. So many people are getting shoulder treatment for their shoulder pain. And it's been our experience that stiffness and asymmetries in the shoulder rarely has anything to do with the shoulder. That's stiffness being fed in from somewhere else. Some of you are sitting out there thinking, wonder if I need my pelvis adjusted. I get to make friends really quickly. I invade people's personal space within minutes. But the results are great, okay? So it's a good time. Ask some of Connor's guys and girls who got the pleasure of me invading their personal space about a month ago, and they'll tell you all about it. So what this does, though, is it systematizes for us, one, how do we truly evaluate a pain condition? It's not special tests, the Hawkins-Kennedy. It's not all these different things on the checkbox for a physical therapy evaluation as one might think or receive elsewhere. It is, does this person move correctly? And we know what correct movement is because we've reverse engineered it thousands of times at this point, because the person who moves like this has pain, and then when we make them move like this, they don't. That's a pretty clear indicator. Because what is pain? You guys know what pain is? Somebody just go for it. Anybody else? A response to life. Yeah, if your body is not ready for life, that will be its response for sure. Pain is a feedback loop. It's just telling you need to make some changes. Those changes are non-specific. We use the example of the transmission. A transmission has 800 unique parts. How many lights are on your dashboard? when something goes wrong? 1. Yeah. So you take it to the mechanic, your light's on. He says, no prob. We'll just cover that light up with some electrical tape. Y'all going for that? Probably not. Okay, we'll just cut the wire instead. You don't like the tape? I get it. Okay. You're not going for that either. You want that guy to get in. He's going to look at all 800 unique parts and say, okay, well, I've seen this 4 million times at this point. We need to do bing, bing, and bing to fully address this problem. That's your body. Okay. So much medicine is A equals 1, B equals 2. This diagnosis equals this treatment. Musculoskeletal health is that stupid math that has numbers and letters. 1A plus 2B equals 3C. You have to solve for all the variables if you're really going to get to the root cause. So we've been able to systematize that through movement and by helping people build blueprints that truly address the rest of their joints, because we know that if we address pelvis first, it gives us the truth about what the rest of their joints are. The other thing this has done for us is allowed us to really understand when do we make a referral. Okay, I worked at Athletico for a couple years before I almost went insane. And then I left and started Energy. But you know how we thought about referrals there? It's like the person still has pain after 4 weeks of doing the same things over and over again, which is what? Insanity, yeah. Hey, we're going to give you this home exercise program. You're going to go home and do that. You're going to come back here and you're going to do it while we watch you do it. We're going to bill you for it. And the only thing we're going to change is your sets and reps. And maybe we add a couple new exercises across the next 8 weeks where you're going to come 2 to 3 times a week. Okay, so and that environment is so limited in what you can do and how much time you get with a patient, it's really difficult to comprehensively treat somebody. So the only play was, hey, we don't know what to do with you, back to your doc. It's not a great pathway. Okay, when you separate out, you zoom out, you look at the whole picture, it's easy to create a system for referral, which looks a little more like this. You have problems in the shoulder, the hips, the ankles, your movement looks like this baby giraffe over here. We need to make it look like this more athletic version over here. Your movement now looks great. Your mobility is normalized in all your joints and you still have unrelenting pain. That's probably an anatomy problem, okay? That's where a disc might actually be a problem, a rotator cuff tear might be a problem, an Achilles strain might be a problem. But you've got to have a dedicated pathway to get there that's not just, it still hurts. Because pain is just telling you haven't made the right changes yet. You have to know what those changes are. And we've been fortunate enough to kind of create some systems around that at Energy because we've been fortunate to work with people one-on-one for a very long time. So, oh, the clicker works now. So this is what we like to do for clients. And when we work with people on site is we want to provide an operational framework. We want to give people a system to operate in, not individual treatments for a specific diagnosis that they might have. So the idea is, hey, let's zoom out. The body functions as a whole. The whole is greater than the sum of its parts, always. Just working the shoulder for shoulder pain is a very narrow view that's probably not going to get you very far, okay? We got to identify their off-target movement patterns. We know movement should look and feel like this. Yours looks and feels like this. Let's start chipping away at these underlying things that make your movement look like that. And it's easy to achieve pain relief very quickly when we do that. Okay, and then we want to zoom in. Once we've zoomed out, looked at everything, now we can focus in and systematically restore these things that aren't working like they should. They probably don't hurt, but they're not working right. Whose ankle hurts in here? Besides you. Nobody's. The ankle is at the root of your pain. Everybody that raised your hand, you have an ankle problem. Okay, it's important to solve. The ankle is like a hidden treasure chest for feeling better. It just is. And I know it doesn't make any sense. You guys are looking at me like, this guy's a whack job. He's in jeans and a hat. But the truth is, all your joints are important because when you move, you walk out of here, every single one of your joints is in motion, okay? You start adding load or speed or athleticism. On top of that, you start adding chair time, travel time, to where now your joints are getting stiff at a rapid rate. These are creating problems in all your joints. That's going to stack up somewhere in the form of pain. Excuse me. And then finally, really the transfer of valuable skills. We don't just give people things to do. We teach them how do you self-mobilize? How do you do your own joint work, manual therapy, the things that the pros do? We teach you how to do that to yourself, not only for your joints, but for your muscles and for your movement. How do you assess yourself? This is key. Everybody says prevention is key. How do you do that in musculoskeletal health? Check yourself before you wreck yourself, okay? There's an easy way to decide, okay, does my ankle move enough? Yes or no? Do my hips move enough? Yes or no? And if the answer is no, now you have the tools in your toolbox to make it a yes, okay? It's as simple as that. And on a grander scale, what we want to do for people is give them choice, right? The first choice people make shouldn't be to go to the doctor. Primary care, like your list, your continuum started way up here. What are things we can modify before we ever get to primary care? You should be able to take a really good crack at solving your own pain before you ever make the next choice, okay? If you decide to go see a professional, it should be your next choice that you are choosing to make, not the only choice that you have. And with a framework that you can operate in, understanding, okay, this is how I check myself. This is how I sort the kinks out. This is how I'm supposed to move. It's very easy to navigate that. And, you know, he mentioned all these things. We do that at NRGPhysio for clients in the clinic. We do it at NRGPhysio Co., which is an offshoot that we do it online, so we can work out of the state and not really get into licensing problems. Conversational AI, which is a very easy way to start. It includes all of our proprietary information, walks you through the Keystone Reset, all via text. So we've taken these self-evaluation, giving you the tools in your toolbox and some pretty easy ways to receive it. On-site, in-person, digital, virtual, some conversational AI. And we've only been able to do that because we took the time to zoom out, work one-on-one, so we know when somebody has this problem, we know what to zoom in on for them so that we can get them results more rapidly. Because if you don't solve pain quickly, people are going to just keep looking for something else, and that is going to cost more money, even if we're just talking about for the person, okay? People spending more money, it creates a lot of problems. What's the number one reason for bankruptcy? Medical debt, okay? So even though maybe employer is still paying for some of this, it still stacks up really high on the consumer. And that's who we have a heart for first, is the people that it's affecting the most in their lifestyles, their families, their leisure time, but definitely a financial burden to have pain for long periods of time and get a lot of stuff that doesn't work. Appreciate you guys.
All right. Thanks, Dr. Chad. I think one of my key takeaways is check yourself before you wreck yourself, which that was great. But in all seriousness, we've actually deployed Dr. Chad's Energy 360 within our organization. And we had a success story right out of the gate where, no joke, he said, hey, if you're having pain, you can stay after and I'll work with you. And we had someone in our workforce who's lived with some pain for a really long time and left that meeting with no pain at all, engaging with Dr. Chad. And that's a game changer. I would like to invite all of our speakers, to the stage, and we're going to do a Q&A session. So I'm going to give you ground rules for that as they make their way up. But first, you have a sheet on your table. And what this sheet has is a ton of resources that are accessible through QR codes. How fancy. But the first one, which is really important, is the survey. And we would really like for you to complete that and give us your honest feedback today about your experience and what you've learned, and that sort of thing. So this is what this looks like. It's the QR code on the top. Now, we are going to do a Q&A session with our panelists. So this is where I invite you all to ask your questions. And if you don't, I will have the time of my life up here and I will fire away my questions, which that's fine too. But we have a panel of experts here that really give us an alternative way of thinking about healthcare. That's the purpose of today. Because the current or traditional way of healthcare delivery isn't working. I think a motivation real quickly around what we wanted to talk about today was around the reason why we want to talk about population health is I kind of think about it in a box and dividing that box in thirds. The bottom box is about primary care, and our part 2 will talk about primary care and steerage is what Nelson mentioned. So that will be addressed there. The top third is our large claim risk. We've talked about that a lot over the last several years of how do we deal with specialty drugs? How do we deal with really expensive treatments that are coming out? How do we change the supply chain around healthcare in those instances? Because that's where the money is. However, over the last year, what we've seen is that middle box, and that is the cost to treat chronic care. And we've seen from a pharmacy side where we're changing out, a couple $100 worth of diabetic treatment for $1,000 of diabetic treatment. And that type of trade happening across multiple disease states. And if we're doing that by the hundreds, that creates a cost problem for employers. So I think that is really important to highlight, and this team is really good at thinking differently. The last thing, just to put in your mind around just this room, okay? We're in a city of almost 2 million, metro, and we have around 100 people here. And even in this sample set of people here, we have health plan spend that probably is approaching $200 million just represented in this room. So just to think about the impact that not only that you can make as an employer, but it doesn't take much to create big impact. So just something to think about. So I'm going to start with Eric quickly. One thing you mentioned that I actually am really interested about is you mentioned a medication shortage. Can you talk a little bit more about that?
Yeah, absolutely. We have, in 2014, we had 320 drugs unavailable, either on shortage or just completely unavailable. Currently, we're at about 330. So this is a record we're at. More importantly are some of the medications we're having issues with. Obviously, the GLP-1s. And there's multiple reasons for this. GLP-1s actually happens to be the pens. The company making the pens can't make them fast enough. There's plenty of medication to put into the pens. We just don't have enough pens right now. And frankly, I think that problem will last throughout the year. More importantly, to a general population, there are 2 drugs, atropine and epinephrine. Those are the only 2 meds in a crash cart that actually help if someone dies and we're trying to bring them back in a hospital setting. Shortage of those medications, so your crash cart may essentially be empty in a hospital setting, which can be quite concerning. Adderall and amphetamine salts are running very short right now. So if you are someone who has ADD or ADHD and you've been taking that medication and been well, they're nearly impossible to find right now. And that has to be, the government gives a certain amount of amphetamine salt quotas to people, to manufacturers. The manufacturers have not been taking their full quota for several years. They're now seeing a shortage. So once these shortage happens, once they happen, unfortunately, we tend to get behind the 8 ball and it's really hard to catch up. And so it's a concern. And cancer therapy as well. Cancer therapy tends to run in groups of meds. So it's not like you can just take one, and if we can't find that, we can plug something else with the other 2. We have to run these 3 together, these 3 together, these 2 together. So if one of these 3 is missing, that regimen is unavailable for treatment options, and that can be quite concerning. So there's a lot of different reasons. Some of it's just manufacturing, like the pens with the GLP-1s. Some of it is the manufacturers. Most of the medications are generic, and the only way to, eventually what happens, we initially get a huge surge of multiple generic manufacturers to market. And then there's a race to the bottom in price until we eventually get just 1 or 2. If there's a problem with one or two of those on the manufacturing side or on an analytical side, or heaven forbid, there's a problem with what we think is in the med and what is in the med. When there are only two manufacturers, we're struggling there to ramp up quickly, and no one really has an incentive to do it. And frankly, if the medications are really cheap, the manufacturers aren't losing a lot of revenue. So I don't want to say they don't care, but if you're losing a couple $100,000 in revenue a month, there's bigger fish to fry and worry about. So there's concern.
They may not care.
I can't speak to that.
And if you have a question in the crowd, just raise your hand and get Zach's attention, and he'll bring a mic your way. But I don't see any hands, so I will continue. Dr. Chad, how does care for physical therapy that is reimbursable by insurance limit outcomes in the root cause solutions for pain?
Good question. Couldn't ask that better myself. So in the insurance network, many of you probably know it's pretty high volume. It's not high volume because they want it to be. It's high volume because it's reimbursed very low. And so, to meet revenue, keep the doors open, they have to see 2, 3, 4 patients an hour. So I can speak to this from my own personal experience and getting to watch, dozens of other therapists that, I kind of came up with in my first 4 or 5 years before I went out on my own. You can get about 15 minutes with a client, and it's just difficult to really do some higher level problem solving for that person. So they're going to spend 15 minutes with a therapist, and they're going to spend the rest of their 75 minutes with therapy tech, basically taking them through their home exercise program. And that plays a huge role in really being able to deliver a certain outcome, just because of the time constraints due to volume. Some other constraints, and that is driven by insurance specifically. The other one is that insurance won't reimburse. If you have a diagnosis code for the low back, they will not reimburse for direct time spent treating an ankle. And so you can't even zoom out and start to look at the bigger picture because of the way that diagnosis codes are reimbursed through the insurance. So if you have to document everything you do ethically and morally, meaning everything you do has to be documented and justified for why you build what you build, then you start to run into some dilemmas of not getting paid for time spent doing certain things. And that's another driving force behind poor outcomes.
I think that's a really interesting thing to think about, and probably a takeaway just from an employer perspective is looking at the ecosystem of your health plan, and how can you look at inefficiencies that exist, because ultimately then physical therapy is incentivized to just check a box and get paid, and if they get better, great. If they don't, sorry, right? So how do you build a health plan, or is your ecosystem allow you to plug in solutions that actually care for your employees? Novel concept, I know, but to think about what that looks like for you and really to pursue those answers, I think are really important. So Brian and Kelly, I have a question for you. And the question is this: when people say wellness doesn't work, has anybody thought that here? How do you address that? And how do you show that it actually does? I'd like to start.
I mean, honestly, sometimes it doesn't. We'll just put that out there, right? So when we look at that continuum, there are programs that are out there, again, that are surface level, that are a check the box kind of a program. And so, yeah, sometimes it may not. What we like to think is if you're doing the right types of things, if you're measuring the right pieces, if you're being specific and purposeful about it, that it can. And sometimes it means redefining it. Again, like I even talked about, it's like it's gone through, even in our careers, a whole realm of evolution, right, of what it means and that. So, but each of those pieces, sometimes you have a missing piece in there that just isn't working.
It's really interesting around just what you're talking about is like if you have a strategy going in and what success looks like, you can have outputs coming back. You probably could say the same about health insurance, that doesn't work either.
And I would argue that that's a strategy problem also. And that's why it's not successful or it doesn't work well. So interesting. Brian, what are your thoughts?
My take might be just a little different. What is wellness? Right? I would argue that it works very well. I would argue that wellness programs don't a lot of the time. But in the 1940s, there was this gentleman way ahead of all of this. His name was Halbert Dunn. And if you don't know anything about Halbert Dunn, I would recommend reading up on him. He's kind of the father of wellness. And ultimately, the way I define wellness and the way he defined wellness way back when was functioning optimally within your current environment. And if you can pull together the right pieces to function optimally within your current environment, you are going to function well. Now, whether or not a program is designed to empower you to function optimally is a different story. One-size-fits-all approaches don't work. Tech platforms that address everybody, those things don't work. It's the technology, I think, Ben, that we've talked about, how wellness has become known, especially by the broker community and many employers. It gets a negative stigma. And I'm not here to change the word wellness to well-being or to something else. Wellness is something that needs to be understood better by employers, and we need to put strategies in place that actually work. Defining specific populations, like you mentioned, is one way to do it, but we have to take it seriously as a business strategy and not an afterthought, and first understand what it actually means.
I like that. Have any questions? There we go.
First and foremost, thank you, Ben, for, again, everything you've put together here with your team. Thank all of the panelists for coming in and sharing the insights with us. My question is a two-part question, and it's really for everyone. So if you could, maybe table topic style, pass the mic, so to speak, and to each one address it from your various perspectives. But the question is, what do you believe from your perspective is hindering a more widespread adaptation from employers from taking on an MSK, a preventative, a wellness, a PBM, and or like a Quantos related type of approach to looking at their health plan? So again, what's hindering them? And then if you could deliver maybe a one-liner to that employer right here, like they're sitting in the room, what would you say to them to get them to really open their mind and explore more?
Not everyone at once.
Yeah, I can start. You know, I think in the PBM side, in the pharmacy space, you know, most medications are Band-Aids. They're designed to treat the problem. So blood pressure, for instance, we have a lot of classes of medications to treat hypertension. Almost none of them address the problem, right? They just work in different ways to lower your blood pressure, which is good. Certainly, I'm not saying that. So I think from the PBM space, right, we have the concept of what medications actually do from a clinician standpoint, but the other side of the coin is how we pay for medications is really off. You know, we've got every new gene therapy seems to add $1 million to the cost. Zolgensma, for instance, which Ben and I have a very interesting experience with. I think we got a Zolgensma patient 2 days after it hit the market.
Yeah, it was
right. 600
lovely luck.
600 children a year. And when Zolgensma came out, we were told this is a cure for spinal muscular atrophy. Well, it wasn't a cure. I mean, most of the patients born with that have already had profound in utero damage. So now Zolgensma has changed the thing. Well, this treatment, this is a mitigation, right? And so we have to be very careful about medications that are coming out, where they're at, how we pay for those, I think has to be different. So my one-liner coming out of that, you know, for employers would be to embrace discomfort, think differently, and don't be afraid to make some change for the betterment of your employees' health. Again, that every decision you make, sure, there's a bottom line side, but if you can make people healthier, you can certainly make good decisions across the board on healthcare and costs.
I would agree with just chasing the root cause. So we've heard of that a lot too. So even like Brian said, of course, being well and staying well works, you know, that does work, but what does that mean? How do we get to that root cause of what's actually happening? And so again, you know, putting those pieces in place, empowering people to take action. I mean, I talk to a lot of people on a daily basis that just don't feel empowered, right? So employers don't feel always empowered. individuals don't always feel empowered. So how can we encourage them to know what's out there, but also how to utilize it properly, especially to get to that root cause?
If you don't mind, I think to address the question around, you said, what's hindering employers from taking action, right? And I think a lot of times it's budget, and they've been there, done that, spent the money, didn't work, right? So now you have this negative stigma that's associated with wellness or preventive care or whatever it might be, and it can be expensive. They have to spend the money on the right things. But also, in order to ensure success, you have to build an infrastructure for that success within your organization. If you were going to stand up a new department, you would ensure that those people in that department were trained in order to, that they're going to function well in that department, whether it's finance or something else. There are trainings so that people can best do their jobs. What we do in wellness, and where we've seen it fail, is that we've handed it to, Ben in payroll. And Ben doesn't have anything better to do. We'll have Ben do it in payroll, and he can run the wellness program because, again, it's an afterthought. It shouldn't be that way. There are highly trained people in this profession that know how to do it and do it the right way, but we don't dive deep enough into taking it seriously enough. What we look for are problems that are usually technology related or something to solve all of our problems, and they're not going to do that. So we'll continue to have negative experiences. As the broker community brings solutions to employers, they need to think bigger and better and more strategically about what those are and whether or not they're going to actually make an impact. And understand also the fact that we have a new generation of workforce coming. It's called Generation P. Has anybody here heard Generation P yet? One person, right? And you work with me. Generation P, we've got Generation X, we've got, whatever we have. Anyone that was in third grade or above up until the, this current generation is deemed Generation P for pandemic. And they're coming into the workforces very soon. Right now, a lot of them are in college with all kinds of mental health issues. And those mental health issues are leading to productivity issues. They're leading to issues in just general well-being. So understand that this is a cultural thing, and embrace the fact that the workforce coming in is going to be your workforce, and take it seriously. I think those are a couple of the things, and I could probably go off, but this is a panel. So those are a couple things I think that hinder the success or the way that we look upon it.
You or me, Nelson?
Go ahead.
All right. Well, there's been a lot of good words passed around already. Appreciate him saying all that for me, so now I don't have to. And I think comfort is an easy one. But when I think about businesses deciding what are they doing, they make decisions from the top down. And so I think at the very top, whoever is driving the direction of that business has to have a culture of wellness on mind with a longer time horizon in mind. I think there's such a narrow window that employers want to see results in that make it challenging, because a lot of this stuff really needs to probably be viewed over a 3, 5, 7, or 10-year time horizon. But I think some of that is because businesses are good at thinking on long time horizons, but they do that in terms of revenue and growth. And products, services like we're talking about, I think are viewed more as defense rather than offense. It's an expense rather than investment. So it really just kind of narrows that time horizon down even further. And so just as I see the hurdles for employers, is it driven from the top down? Hey, this is what we're doing and this is where we're going. And is it explicitly clear, when are we going to arrive? It's not just we're going. Because if you don't know where you're going, it's very difficult to get there. So I think having that clear direction, strategy, what is considered the outcome that we're looking for? I think there are so many outcomes to consider besides just cost savings when you look at the broader impact that it has on employees' lives, and kind of tying all these different facets together into the decision versus just how quickly can we get a return on investment. And they call it return on investment. It's like, how quickly can we make our money back? So it's not an expense anymore. Mm-hmm. And we have that conversation with quite a few employers. It's a difficult hurdle to overcome sometimes.
I'm going to take it a little bit higher level, if I can, because this has been a fascinating day, and I hope you all appreciate. You don't understand what you've seen, how different it is from what's going on in other seminars like this around the country. This has been wellness, and everybody's talked about outcomes, not process, but outcomes. Every one of you has talked about outcomes. That is so freaking unusual. To go to your question, which is a great question. All of you in this room that offer an employer-sponsored health plan intend to provide for health care for your employees, correct? Yes? You're doing that in a system that is not a healthcare system. And it's been said earlier, it's a sick care system. And your program, your healthcare program, doesn't pay for health. It doesn't even pay for care of health. It pays for care of sick. So you're providing payments for drugs, surgeries, other procedures for people who are sick. And the system only gets paid when they take care of sick people. What you've heard up here is, let's take care of people who aren't necessarily sick yet or aren't very sick before they get really sick. Ben and his team for the last, 7 years or so have been addressing the supply side of healthcare, the supply side cost of healthcare. And it's easy to do because 25 to 30% of healthcare spend, and this is your healthcare spend, is fraud, waste, and abuse. It is a big, fat, juicy target. And Ben and his team have been so effective in carving out a lot of that fraud, waste, and abuse. But there is a demand side of healthcare that doesn't really get addressed. By the way, most wellness programs, as you know them, do not work. I have a friend, Al Lewis. He is a data scientist with the Validation Institute. Al Lewis has a $2 million prize on the table, backed by, I think, Lloyd's of London, who will fund it. That award is available to any wellness company that can prove a financial ROI. No one has even tried. The typical wellness programs are check the box programs. Run a 5K and we'll give you a gym bag. So everybody who runs 5Ks is going to get a gym bag. It's not going to induce anybody. The problem is the system doesn't work for health. And what and you and I've had some conversations about this before, and I know it's informed by putting this program together in part and working with Kelly and Brian and the rest of these people up here. There is an opportunity to create a healthcare system or a healthcare plan that actually pays for your employees to get healthier, which when that happens reduces the demand for healthcare. Not that someone can't get healthcare if they need it, it's they don't need it. If they aren't obese any longer, if they don't have pain, they don't need opioids because they don't have pain. Therefore, they don't get addicted. And now you've got an addiction problem. So I keep hearing root cause up here. Wow. Medicine in this country, and I loved you talking about this. There's a reimbursement problem. There is something called reimbursement. Medicine, you get paid by what the insurance companies will reimburse if you're in healthcare, whether you're a hospital, whether you're a doctor, whatever type of practitioner you are. So those of you, this goes to your question, I think, those of you who run healthcare plans have to think so outside the box. Ben mentioned I'm an outside the box thinker. He is. This is why you've got this panel up here and not your typical blah, blah, blah panel that you're going to leave and go, I don't know what they said. It doesn't matter. Back to work. If you haven't been challenged and your thought process invigorated by what you've heard by these guys, not so much me, I'm talking big picture, but they're in the trenches. It's going to take a mindset change that we're no longer going to be constrained by what the insurance companies will pay for, because they aren't going to pay for a lot of what they do. You want to carve out GLP-1 drugs and you want to do coaching, I don't know how you get reimbursed for that necessarily. We're not going to give you a GLP drug until you go through this program. Make sure you're suited and you're going to follow through. And first thing y'all are going to ask as employees is, well, how would we possibly do that? Well, you wouldn't. You turn to an advisor or consultant like Ben and say, Ben, what do we do? And Ben finds you a solution, a vendor, a solution provider. So it's an outside the box thinking approach. And this has been so fantastic, I think, to give people a sense of what you can do to change the system. Because otherwise you're just going to keep paying for more drugs, more surgeries, and you're getting ripped off every time you do. And Ben will do his best to cut costs, but can you cut demand? And really, who is this healthcare plan for, Ben?
Employees.
It's for the employees. It's for your employees. So don't we want them to be healthier? And that's what you have the opportunity to do. So I think it's mindset. It's the system doesn't let you really do the right thing. You're going to have to force the system to allow you to do it.
That's good. I want to, from a consultant perspective, answer your question, because I actually have a lot of empathy for employers in the room that, like it or not, you are in the business of healthcare, in addition to the business of the widgets or turkey farming or whatever business you're in, you are also in the business of healthcare, which means you, by proxy, in the role that you're in, are involved in making decisions that affect your coworkers' navigation of the healthcare system. That is not an easy position to be in. However, I think it is a great opportunity to deploy exactly what was just said. And what Nelson and I talked about last night at dinner is a large issue outside of the delivery system adjustment that we talked about today is when we walk in to talk to an employer, usually there's no strategy. It's how does my renewal cost not as much as Blue Cross wants it to cost, United Healthcare wants it to cost? Like, how do we solve that? It's like, it's not the right question. Like, how do we build a strategy where this is sustainable and we're actually serving our workforce? So that's what we typically see as an issue when we go into talk with an employer. And that's a hard thing to solve for, but a lot of the employers we work with deeply care about solving for that. I think I saw another question. Yes.
Hey, great panel today. Learned a lot. So I guess most of us are safe to say we're here because we care, right? We're here to listen to what you have to say. So my struggle is we can bring it in, but you can't take a horse to the water and let it drink, right? Our employees, you give them a shot. It's one easy thing. That's what they're going to do. You're telling me I got to do something different and work on it? Oh, no. My doctor will give me a shot. So my thought is, and I don't even know if you can answer it, is how do we get to the doctors to do this right? To give them a different plan to help them out, right? Because I really think that's where it settles, is where they're getting their health care. And again, give them a shot, they're going to take the shot. And so I don't know how we fix that, but that's open to anyone.
So having worked in the healthcare system for a long, long time, I appreciate the question, but this is the only part of our lives that we let someone else make such massive decisions for us in our physician, right? I don't use the Kroger personal shopping app. I tried that one time when my kids were young and they brought me like the crummiest apples. I'm like, well, who chose these apples for me? We've let physicians be the consumers of healthcare. Right? So if you're in the hospital, you think you're in charge as a patient, but you're not. You get to choose your lunch with restrictions because you can't have salt and you can't have good food and it's going to be awful. But your doctor's picking your labs, they're picking your surgeon, they're picking your treatment, et cetera, et cetera, et cetera. I think it's an education thing for patients to get them to understand you are in charge of your health. You're in charge of what you eat every day. You're in charge of whether you move. You're in charge of, as an employer, you pay for a wellness program if you show up and do what they told you and do that. We have to, as patients, act like consumers as well. We have to make our own choices. So physicians are under so much, and I'm not justifying the mistakes that get made. One of the hospitals I worked at, I was on the, we called it the RHC committee because we wouldn't actually, respirations at sea, so we wouldn't actually call it the death committee, but that's what we were investigating. I got thrown off that in like 6 months because I'm like, our fault.
It's not a popular answer.
You're gonna get it sued. I'm like, well, we're here to learn and not do it again, right? Well, not really. But you know, there's a local hospital system that just told their primary care doctors, after 2 questions, you start charging the patient more money. Is that the physician's fault or is that the system's fault, right? Oh, by the way, it's a not-for-profit, Nelson. So,
So I actually talked to someone the other day whose daughter went into her physician. She asked 2 questions. She started to ask a third, and she was told, you'll need to set another appointment. I cannot answer another question in this appointment. True story. So it's what a wonderful question, because the doctors are the gatekeepers. I have had physicians tell me in the standard working for the insurance company, because they do work for the insurance company. What do you hate about your job? I have 5 to 7 minutes on average to meet with a patient. Not a lot of time. The patient wants something. They're there because they're sick or hurt. They don't feel good. I have time to do one of 2 things. I can write them a prescription, or I can write them a referral to a specialist. That's all I have time for. Education? Are you kidding? I don't even have time to find out what's really wrong with them. I have to kind of take their word for it. So it's a reimbursement issue in part. Those direct primary care, I think you said we have a DPC doctor here. Yep. Direct primary care doctor exits the system of insurance so he can spend more time and dig in deep and come up with options other than a drug or a specialist.
Mind if I respond to this? Physicians live in time poverty. Bottom line. As we move towards value-based care and everything, right? We are moving towards a system that reimburses based on the quality of care that we provide, not the quantity of care that we crank out. And if you think a doctor has the time to do what you just said, to sit with a patient for more than 7 minutes when he's seeing 14 patients in a half-day session, you got another thing coming. 15, 20 years ago, there were these obscure people that used to sit in the corner of a doctor's office. Doctors didn't know what to do with them. And they were known as these things called nurse practitioners. You probably heard of them now because they're the standard of care. They're physician extenders. We have an infrastructure problem in healthcare because physicians are suffering from time poverty and they are expected to just crank. Now there's these obscure people sitting in doctors' offices called health coaches, and nobody knows necessarily what to do with them, but they're slowly becoming the standard of care. We have a reimbursement problem for these services, but just in January, the NBHWC, which is the National Board for Health and Wellness Coaching, and you know about this very well, approved level 1 CPT codes, reimbursement codes for health coaching. So we're moving in the right direction. I didn't think this would get there for 5 years at least. But it's not a doctor problem, it's a system problem. We have a system that is built on time poverty and just quantity, cranking it out over and over again. We have to rethink who's doing what work and what's the most impactful work that we can do.
Very good. In light of time, we need to, and I feel like our Q&A is picking up steam, but and we could probably be here for another hour, but in light of time, we're going to end our session today. So I wanted to thank you guys for participating today and giving us a way to think about healthcare differently. So one thing real quick, though, to just maybe add on to that question is I think it's our job to continue to educate employees that a care team is partners with people for their health care or to treat their condition. It is our employees' responsibility to be involved because, as you heard on the trailer documentary, you heard with Nelson's information as well as how we receive care. Like when we go into a surgery, that is potentially a life and death moment. And we have to help employees understand how serious it is as they engage the healthcare system. So thank you for coming. Please fill out the survey. Thank you to our partners, Imagine 360, TrueRx, Stealth, Wellbridge, Delta Dental, TPAC, RX Help Centers, and UGS. Again, they're the cheat codes to how to make all this work. So thanks again for coming, and have a wonderful rest of your day.